Good morning, colleagues. Good morning, honorable members.
Morning, Zomo.
Recording in progress.
morning, honorable members. Good morning, colleagues. There are only two members that have not joined so far. As soon as we have accepted them and they are part of the meeting, we will start our meeting. So far we have 6 members. Mr. Ryder has not joined yet, and Mr. Khadet. So we're only waiting for those 2 members, and then we'll start the meeting. Thank you very much. Okay, morning, honorable members. I am thinking that in the interest of time, we can start the meeting because the committee does form a quorum. We have 6 members on the platform. We have Honorable Ndlovu, Honorable Numalo, Honorable Swartz, Honorable Bits, Honorable Majola, and Honorable Siwisa. So since we do have a quorum, I think we can start the meeting, honorable members. Is that in order, honorable members?
Yes.
Noted. Thank you very much, honorable members. Honorable members, let me flight the agenda of today's meeting, and then we'll proceed with the meeting.
Mr. Nodad,
Hello, honorable chair.
there is a the person by the name of Hisense U71. Can you ask that person to rename him or herself? I don't think we should continue that.
Okay,
platform.
thank you very much, Chairperson. Let me prioritize that matter. Colleagues, can you please assist me? The colleague who has joined with a gadget Hisense U71, please indicate your name so that we can rename yourself as soon as possible. The gadget is Hisense U71.
Morning.
Yes, sir. Who was that?
With Robert Mailula.
Oh, Mr. Mailula.
Yes.
Okay, thank you very much. Let me rename yourself and then we'll proceed with the meeting. Thank you, sir.
Okay, thank you.
Thank you. Apologies for that, honorable members. Honorable members, this is the agenda for today. Let me go to the beginning of the agenda. So we have got a small item of electing an acting chairperson. So I'm going to assist the committee with respect to that item, and then thereafter I will hand over to the committee to proceed with the meeting. Good morning, honorable members and colleagues. Good morning, chairperson of the FFC. Honorable members, as announced by Honorable Lekhwase on Wednesday, the 29th of October last week, that she is going to be out of the country this week attending the SA-EU Interparliamentary meeting in Belgium. As a result of that, we have received an apology from her because she's unable to attend this meeting. It is due to that today, as meeting agenda has an election of the chairperson item, which must be done in accordance with the Rule 151 of the NCOP. The rule states that if the chairperson is not available to attend or perform the functions of the chair, the remaining members of the committee must elect one of its members as an acting chairperson. So the procedure is going to be a brief, honorable members. It's going to be as follows. I, as the secretary of the committee, I will preside over this process. I will invite the members to nominate one of the committee members to chair the meeting for today. A member will mention his or her name and will move and nominate the member that will be a preferred candidate for chairing this session. A second member mentioning his or her name will second the nomination of the member. Members may nominate two or more names. If members decide to do so, the nominated names will be put to a vote, and the member with the most vote will then take the chair and proceed with the business of the committee. If only one member is nominated and seconded, and members do not nominate a second name or third name, the nominated member will then take the chair and proceed with the business of the committee. And now, honorable members, move to the process of electing an acting chairperson. I invite members to nominate an acting chairperson amongst themselves. By show of hands, please indicate the member. Okay. Honorable Ndlovu.
Thanks, Mr. Nodada. I nominate Honorable Ngumalo. Sylvia.
Sorry, honorable members, my mic was muted. Apologies. Honorable Ngumalo, do you accept the nomination?
Secretary, I do accept the nomination.
Thank you, Honorable Ngumalo. Any second, honorable members? Honorable Siwisa, I see your hand is up.
I second that to note that.
Thank you, Honorable Siwisa. Honorable members, is there any other name that you wish to raise? Going once,
Accept
twice.
nomination.
Okay. Come again, Honorable Sat.
Accept the nomination, Chief.
Honorable Sat, I did not hear any member nominating you. Oh, you accept the
I agree on the nomination that was on the table. I accept that.
Perfect. Thank you, Honorable Swart. Honorable members, let me not waste your time. Honorable Ngumalo, you are duly elected as acting chairperson of the committee. Please take over the meeting. I am going to flight the agenda now. You'll move from the item of opening remarks, and then you'll handle the meeting. Thank you, ma'am.
No, thank you very much, honorable members, for having confidence in me to chair this meeting. I am in the Bundus of Mpumalanga, so I will have a problem with the video. So what is important is that honorable members and stakeholders I want to greet you all and welcome you to this public hearing of the Special Appropriation Bill B22 to 2025. The meeting of today is convened in terms of Section 59 and 72 of the Constitution, which require Parliament to facilitate public involvement in its process and in line with the Money Bills Amendment Procedure and Related Matters Act, which empowers the committee to consider and, when necessary, recommend amendment to the appropriation. Honorable members, the bill provides urgent funding to sustain HIV and AIDS, TB, and community health outreach services following the withdrawal of a donor support. In doing so, it helps prevent regression in accessing the health of our people. In doing so, it helps also to prevent the regression which is done and to protect under Section 27 of the Constitution of the Republic of South Africa. Our task today, honorable members, is to ensure that this funding is not only adequate and timely, but it will be implemented effectively at the provincial and community level, and it used to remain transparent and accountable. In line with Section 213 of the Constitution and the PFMA, we therefore welcome the insight and the recommendation from today's presenters, which will assist the committee in accessing the bill impact, risk, and also sustainability consideration. Thank you very much, honorable members. We now invite our first stakeholders to give us their presentation. Let me check let us start with the apologies. If ever there's any apologies, honorable, note that I'm used to this, honorable. Is there any apology other than that one of our chairperson?
Thank you very much, Honorable Whip and Honorable members. Besides that apology, we have two more. An apology from Honorable Brits. He has a meeting which is clashing with this meeting, the meeting of the Joint Ethics Committee that he is chairing. So Honorable Brits wishes to be excused after the FFC submission. The third apology is that of Deputy Minister Sarupen. He's also unable to join the meeting. Thank you, Chair. I see Mr. Chen's hand is up. It might happen that he has got an apology for the chairperson of the FFC, Dr. Mbaba. Through you, chairperson, Mr. Chen.
Yes, yes.
Good morning, Honorable Chair and Honorable members. My name is Chen Tsang, the Head of Research at the Financial and Fiscal Commission. I would like to record an apology from our Chairperson, Dr. Patience Lombeko Mbava, who is unfortunately unable to attend today's briefing due to prior commitments. However, I shall be in her stead, standing in her stead, to take you and to make our submission to your honorable selves. Thank you very much.
No, thank you very much. The apology from Ms. Mbava. We now continue. We are done with the apologies. We now continue to the next. Let's go to the agenda. Can we flag the agenda so that we may follow it accordingly? Okay, thank you very much. We are done with the apologies. We are taking the next one, which is the briefing by the Financial and Fiscal Commission on the Special Appropriation Bill B22 to 2025. I will now hand over to the FFC to take us through this bill.
Thank you, Honourable Chair, and good morning again. Without further ado, let me first of all thank this committee for having given us a generous invite to brief you on the Special Appropriation Bill. Honourable Chair, members, this bill comes at a time, notably, that it just a few days before the medium-term budget policy statement, and in so doing, I plead that three specific questions be considered, and as our recommendations and submission to this committee regarding some of the particulars and circumstances of this Special Appropriation Bill. Specifically, question number one is we ought to ask, in the light of that this is only a few days before the medium-term budget policy statement, general terms, it should have been tabled together with, because it's still in-year adjustments, and because normally when we are doing medium-term budget policy statements with the in-year adjustments, the question of allocative efficiency of divisional revenue must come under scrutiny and considerations, especially within it, under the umbrella that is the fiscal framework. So understand that this year of 2025, we tabled by the Minister of Finance and National Treasury, and as a country, we accepted a fiscal framework as shall we say, the size of the pie. And under that size, we ought to consider, in terms of the division revenue, how much is going into what sector, and that the decision of that division of revenue underlies the principles as per our constitution, that it ought to be equitable, it ought to be efficient, it needs to be effective use of the scarce resource that we have. And so in this case, in line with that thinking of allocative efficiency of divisional revenue, comes this special appropriation bill that essentially is taking a further portion of the pie, size of the pie, that is the fiscal framework. And so we ought to think about then, what are the trade-offs? Where did we get this money from, even though it's coming from within the pie of the fiscal framework? And we ought to ask those hard questions, that at this moment, yes, the destination of the allocation is, and the purpose of, is for health. But could we not perhaps think also as well that this money, the reason why behind it is from our international relations? And so we ought to think about some of the backgrounds and the historicities, and where did this demand of money and additional money is originating from, and so we ought to think in terms of the trade-offs between that international relations and the activities thereof to this now health special appropriation bill, that the allocation between these two functions ought to be thought of and re-examined to ensure that the resource that we are allocating today and approve through Act of Parliament is well considered under the banner of this allocative and the principle of allocative efficiency. Number two is the FFC as a Financial and Fiscal Commission in terms of the Chapter 13 and especially under Section 214. We need to consider and have to advise you, Honorable Chair, members, regarding the legislative requirements of the Division of Revenue for implementations. What we mean by that, Honorable Chair, members, is, as you correctly pointed out, Chair, that this bill is, a part of it at least, is for the provinces. And so we ask ourselves a question that from as Financial Fiscal Commission, when we talk these division of revenue, especially of money that's going to provinces and subnational spheres of government, we normally, raise these or allocate this money through the division of revenue bill, not a special appropriation bill. However, we also note that it's incorrect to say that it can only, this money, amounts of money, for whatever purpose, but it is allocated, can only appear either one, because the two bills, one of appropriation bill that decides the national allocations to the votes, and the divisional revenue bill, which allocates money to provinces and municipalities, are totally related. But here, we are only seeing special appropriation bill, which is operating at the national sphere. If we look deeper into the grant framework and the frameworks, in some instance, of this purpose of this fund, is for health, and that the HR be allocated through some of the direct grants to provinces. Then we, as Financial Fiscal Commission, under the principles of financial governance, we have to ask the question, will this and how will it be implemented or be legislated in terms of the Divisional Revenue Bill to maintain the financial governance as well as the fiscal transparency of this money to be allocated. That's the legislative requirements of the Divisional Revenue Bill in relation to this bill. This third and final one is, and which my researcher, Mr. Fabrice, will take you over very quickly, is this finance must follow function. And by function, we mean performances of the sector of health. And so, Honorable Chair members, just a little bit more than a month ago, we were briefing the Portfolio Committee on Health in terms of the performances of the 2024-25 annual reports of the health sector, and that includes not just the national department, but also of provinces and entities thereof. Honorable Chair members, unfortunately, and will be verified with fact, is that the performances of this particular function that is to be funded by PEPFAR or by this special appropriation bill as substitutes have not been performing well. NHI, for instance, have not spent all of their money, and it's more than 2 decades. We still don't see any kind of system that ties and considers and accounts for the risk, health risk, and health and safety risk matters of our citizens. And I think based on these three principles and considerations as we make our recommendations to you and brief you today on this special appropriation bill. Honorable Chair members, then let me hand over to Mr. Fabrice to take you over to this presentation and our submission. Thank you, Chair.
Thank you very much, FFC. You said there's Mrs. Who supposed to continue? Are you done?
It's Fabrice.
Fabrice, okay.
Yes.
Let's keep it.
Through you, yeah, Chair. Let me hand over to him.
Okay.
Thanks, Acting Chair, and good morning to the honourable members. I'll start off by contextualizing South Africa's HIV/AIDS response to understand the why behind this bill. So South Africa has one of the world's largest HIV/AIDS public health efforts globally. This response is primarily driven by the Department of Health, supported through dedicated grants and institutional coordination across government spheres. At the center of this framework is the Comprehensive HIV/AIDS Conditional Grant, which channels funding from the national to the provincial level to support testing, treatment, and prevention services. This grant forms the backbone of provincial HIV programs, financing antiretroviral therapy, prevention of mother-to-child transmission, and outreach across all 9 provinces. The National Health Insurance Indirect Grant plays a complementary role, supporting system-wide functions that underpin the HIV response, such as health information systems, laboratory infrastructure, and the integration of HIV services into the broader public healthcare network. When looking at the entities, the South African Medical Research Council contributes through clinical research, data analysis, and evidence generation, ensuring that treatment protocols, prevention strategies, and policy interventions remain science-based and effective. This network of institutions represents a robust domestic architecture for combating HIV/AIDS. However, its effectiveness depends on predictable and well-targeted funding flows between the national and provincial levels. The Special Appropriation Bill therefore plays a critical role in maintaining the stability, ensuring that provinces can sustain service delivery, research institutions retain capacity, and the national coordination mechanisms remain intact. This slide presents a concise background on PEPFAR, or the US President's Emergency Plan for AIDS Relief, that has been a long-standing international partner in South Africa's HIV response, funding large-scale testing, treatment, outreach, and research programs over many years. If you look at the scale of PEPFAR, it constitutes approximately 17%, or close to 8 billion of South Africa's overall budget for HIV/AIDS programs, which is over 44 billion, and this covers prevention, testing, and treatment. PEPFAR also supports 27 HIV and AIDS high-burden districts across 8 provinces. PEPFAR works through a partnership-based country-led approach, where funds are channeled through implementing agents such as USAID, which in turn appoints and funds implementing partners, including many NGOs and community organizations. This operating model means some of PEPFAR funding activity runs outside the South African government's direct fiscal control, even when they deliver essential public health services at facility and community level. If we look at the timeline around the PEPFAR funding crisis and therefore the need for the special appropriation bill, just to summarize, it started off in early 2005 when the US President Donald Trump administration announced plans to freeze and terminate all US foreign aid in line with its broader America First policy. This then led to the termination of contracts and halt of work on health projects that were funded by the US government, including those in South Africa. In the May budget, the Minister of Finance announced that PEPFAR would, the withdrawal of PEPFAR would necessitate unplanned government funding later in the year. And then we've seen that in a partial reprieve, US lawmakers exempted PEPFAR from planned government spending cuts which they announced in July. However, this has not yet translated into the full operational restoration of PEPFAR, with some activities and funding still remaining frozen. And lastly, in October, the US government approved a $115 million PEPFAR bridge plan, providing emergency funding for 6 months So from the 1st of October to the end of March next year to South Africa to help in its HIV prevention and treatment programs. So, honorable members, this timeline shows quickly how a donor-funded shock can translate into fiscal and service instability. It's therefore important to ensure that our domestic health financing architecture is robust enough to withstand such volatility. If we look at the funding that the impact that these PEPFAR funding cuts have had, according to findings by UNAIDS, the funding cuts severely undermined South Africa's HIV response. So it resulted in a decline in viral load testing. It also led to many community-led and non-governmental organizations being forced to halt outreach, treatment, re-engagement, and service monitoring activities, effectively dismantling the vital link that connects patients to clinics. Purchases of key prevention tools was also frozen. Several clinical research projects were suspended, and there was also widespread redundancies, resulting in labor shortages at many clinics. Moving on to looking at the Special Appropriation Bill. The bill proposes an allocation of 754.5 million from the National Revenue Fund, and this is broken down as follows. 590.4 billion to the Comprehensive HIV/AIDS Grant to sustain provincial service delivery, 132 million to the South African Medical Research Councils to safeguard research capacity, and 32.1 million to the NHI indirect grant to stabilize underlying systems previously supported by PEPFAR. These funds are a lifeline, but the Commission would like to reiterate here that it's only a short-term fix. They plug an immediate gap, but we don't yet have an idea of the long-term pathway when it comes to HIV services and how to again mitigate against such shocks should they happen in the future. When it comes to the implications of the Special Appropriation Bill, honorable members, this bill treats the symptoms. It also creates new pressures. So our analysis reveals several key implications. Firstly, fiscal pressure. The 754 million is redirected from the national fiscus, adding strain and inevitably crowding out other pressing social needs. Secondly, the provincial burden. The bulk of the funds flow to an already overstretched provincial health departments, which could risk implementation delays implementation delays of any AIDS-related work. Thirdly, NGO uncertainty. Right now, it's unclear whether any of these funds that have been allocated by the bill will flow to the NGOs who are the backbone of service delivery when it comes to the country's HIV/AIDS response. And finally, as I mentioned before, this is a short-term fix. This is which leaves the country potentially exposed to further future donor volatility. When looking at the outlook, the external environment remains highly risky. While the PEPFAR bridge funding plan that I mentioned earlier provides some relief, the combined value of the bridge plan as well as the Special Appropriation Bill funding only replaces about 36% of the annual funding that the country has lost. More alarmingly, PEPFAR's future is fundamentally threatened by the America First policy, and this compounded with rising geopolitical tensions could result in punitive cuts by the US to health funding to South Africa. So what is clear is that right now we are navigating a uncertain global outlook when it comes to funding tied to the US in light of volatility around foreign politics. So this calls for domestic policy to internalize and look to sustain key HIV programs through predictable multi-year funding. Through you, Chair, I'll hand over to my colleague now to take us through the remainder of the presentation. Thank you.
Thank you, Chair. Thank you, Chair. So,
In addition to the analysis that Fabrice did, we also tried to paint the picture by providing the analysis of the health vote. And what we see here is that based on the analysis that we conducted, we know that the health vote is projected to increase by 1.7% from 63.7 billion that was announced in the 2024 MTEF to 64.8 billion in the 2025 budget. So despite the marginal underspending in 2023-24 financial year, so a substantial portion of this increment is earmarked for supporting the employment of medical doctors, increasing the availability of medical supplies, and the preparatory work for the national health insurance. So this is further in line with the Commission's recommendation in its submission on the Division of Revenue of 2021-22. Next slide, please. So on this slide, we highlight budget performance trends across the department's main programs. So we see that the department recorded a persistent underspending of 3% in 2023-24 across all programs, suggesting ongoing challenges in spending efficiency and program implementation. So as a result, the 1.7% upward adjustment from the 2024 MTEF baseline for 2025-26 financial year may be difficult to justify if the spending capacity does not improve. So in terms of looking at specific select programs, we see that the administration budget is revised downward by 2.8% for the 2025-26 compared to the budget 2024 allocations. This reflects baseline reprioritization, primarily reductions in goods and services. Further to that, the adjustment aims to align spending with actual capacity as 2023-24 saw significant underspending of 15.3% in this program. The NHI budget increased by 0.8% for 2025-26. This aligns with ongoing preparatory work for NHI implementation as initially stated, particularly developing the National Health Electronic Record System. Moreover, the modest increase indicates a focus on building foundational systems before the large-scale rollout. The budget for communicable and non-communicable diseases rises by 0.3% in 2025-26 compared to the 2024 MTEF. These funds are earmarked for capacity building at the National Institute for Communicable Diseases, supporting disease surveillance, public health, and public health readiness. However, the program also experienced a 4% underspending in 2023-24, suggesting ongoing challenges in project execution. Next slide, please. On this slide, we focus on the financial performance by programs. So we note that most major programs achieved strong spending performance in 2024-25, with communicable and non-communicable diseases, primary health care, and health system governance and human resources reaching near 100% spending, reflecting stability in managing provincial grants. However, primary health care and hospital systems also maintained high spending levels, indicating effective grant management. But what we see is that the National Health Insurance Program underperformed, with its spending rate dropping from 94% in 2023-24 to 86% in 2024-25, resulting in 186.8 million underspending, mainly within the health financing and the NHI sub-program. While overall financial management remains strong, the NHI performance highlights implementation challenges that require closer oversight and improved execution. Next slide, please. So on this slide, we highlight the department's non-financial performance for select programs in 2024-25. So we note that under the NHI program, 94.5% of the target was achieved, with 8.98 million chronic medication parcels delivered through the Central Chronic Medication Dispensing and Distribution DEPLAB MEDS program. Furthermore, performance was slightly below the target due to the shift to a 3-month collection cycle and the withdrawal of the US funding, which reduced provincial delivery capacity. In the communicable and non-communicable disease program,
we note an 81.2%. We note that 81.2% of the target was met, with 2.68 million HIV patients enrolled in the differentiated model of care. However, lower performance in the provinces such as Mpumalanga, Northern Cape, and the Western Cape, and a regression in Free State and KwaZulu-Natal contributed to the shortfall. So overall, the results highlight funding and implementation challenges that also need to be addressed. Next slide, please. So on this slide, we look at HIV AIDS-related grants, and the first one we analyzes the National Health Insurance Grant. So here we note a strong national uptake of the grant, with provinces collectively spending 101.5% of the allocated 455.9 million. However, we see that 5 provinces, inclusive of the KZN, Limpopo, Northern Cape, Northwest, and the Western Cape, fully utilized their funds. And inclusive of that, we see that Mpumalanga and Northwest exceeded their allocations by absorbing prior year surpluses. We also note that Free State underperformed, spending only 86.5% of the allocation, and also leaving 3.9 million unspent, suggesting possible implementation or capacity issues. Next slide, please. So on this slide, we see that the comprehensive HIV grant under the district health program achieved a 101% national spending rate, indicating full budget utilization and use of reserves. So we know that 7 provinces spent 100% of their allocations, reflecting efficient program delivery. However, we also see that Gauteng overspent by 2.3%, likely due to cost pressures, while the remaining provinces closely aligned spending with allocations. Next slide, please. So on this slide, we look at the South African Medical Research Council's performance. So what is key to note here is that the council spent only 78% of its 1.8 billion budget in 2024-25 due to delays in the US-funded PEPFAR project disinvestment, which resulted in a significant decline in contract-funded research revenue and associated spending. However, despite this, we also see that the council significantly improved its non-financial targets, more doubling its planned research outputs and exceeding goals for grant, innovation support, and postgraduate development. So overall, the result reflects strong delivery of the council's mandate. Moving to the recommendations, Chair. So first, the Commission welcomes the Special Appropriation Bill as well as the PEPFAR Bridge Plan as necessary and timely short interventions to safeguard the provision of public health care services and maintain the significant progress made in the fight against HIV and AIDS. The Commission recommends that the Minister of Health, in collaboration with the Minister of Finance, develop and implement a multi-year domestically funded financing strategy. Given the government's constrained fiscal position, this strategy should involve a review of the national health budget to improve the efficiency of domestic resource allocation to HIV and AIDS responses. The Commission is of the view that this will ensure the long-term stability of HIV responses, particularly given heightened global geopolitical tension. The Commission is also of the view that the strategy should also actively explore the use of public-private partnerships so as to leverage private sector capital, efficiencies, innovative technology to enhance service delivery and diversify the long-term funding base. The Commission is also of the view that this strategy should include transitional funding mechanism that absorbs such important initiatives into the national budget, as this will safeguard public health gains, reduce service disruptions, and ensure sustainability of HIV/AIDS response services. That brings us to the conclusion of our presentation, Chair. With your permission, I'll hand over to our Head of Research, Chair. Thank you.
No, hand over to the research. Thank you.
Thank you, Chair. Yes, so in conclusion, I think clearly nothing is for free. We always say there is no free lunch in the intergovernmental fiscal relations framework or in economics. This funding Yes, it's coming from the National Revenue Fund. And then under some of the rather strange and circumstances as we presented to you, ultimately we have to remain with those questions. Despite the recommendations, we also remain with the questions that I've raised in the beginning, and just recalling them that there is issues of legislative requirements. There's the issues of allocative efficiency, and then also we need to think of everything in terms of fiscal transparency and in terms of the principles of our Constitution to ensure that finance follows function and that those functions are performing and effective and efficient. Thank you, Honourable Chair. That is our submission.
No, thank you very much, FFC, for the report that you are giving to us. What is worrying so much to me is that Mpumalanga is now number 1 in terms of HIV and AIDS, and it is my home province. It's something that is very much worrying, but what can we say? Thank you so much for the presentations. We are now, can we get to the agenda so that we can follow it accordingly? Let's beam the agenda.
Honorable Webb, is it visible?
Yes, it is visible. Okay, it is now item number 5, where we allow members to deliberate on the matters that have been reported to us. So I will allow, if ever there's any hand which is up, so that we can deliberate on the issue of the FFC. It's something that we can't say we are done. It's something that is very, very crucial, especially on the issue of health. We know the issue of the withdrawal of donor funding from America. It created a gap. So with this appropriation bill, it's there to make sure that it assists. So you can assist me if ever there's a hand which is up for deliberation.
Yes, Honorable Whip, there are a few hands up. First on the list is Honorable Siwisa, followed by Honorable Ryder, Honorable Brits, Honorable Zovo, Honorable Swartz, and Honorable Majola. Thank you, Chair. In that order, Chairperson. Thank you.
Thank you very much. Honorable Siwisa, can you start?
No, thank you, Chair. Greetings to everyone, Chairperson. I hope my network is not going to fail me. I'm in the same situation as you. I'm in the province, Tatumajol, but I think it's stable now. Chair, I've got only 2 questions. There's a concern about the short, and I think I also raised it in the previous meeting when we were briefed about this bill, that even if money is going to be allocated, but the issue of short of staff, delay in procurement, and cost pressure is one of the concerns, because you can't give money if there is no staff. And I'm raising this thing, and I'm going to make an example about the Northern Cape. About a week ago at Masakane Clinic, a 10-year-old was prescribed the wrong medication because of short of staff, because there was no qualified pharmacist at the clinic. The child ended up getting medication for high blood instead of getting medication for asthma. That's where my issue of short of staff comes from. So we'll give, the money will be there, but if there is not staff to actually do the job, then it means that there's a possibility that the Department of Health is going to end up hiring people that do not qualify to administer or do the programs that are in hand. Also, we should also take into consideration, because this is going to lead to the question that I'm having. The report of the Health Ombudsman in the Northern Cape case towards the Department of Health and what was found there. And even now, there are rumors that the MEC is going to be removed. We are not sure how far, but my question is based on, are provinces ready for the expenditure of such a huge magnitude without any disturbance to the testing, treatment, and outreach programs? Are they ready to spend such money, taking into consideration the delay in procurement and the shortage of staff? Number two, the FFC alludes that the solution is not a once-off allocation, but there is a need for a domestic multi-year HIV financing strategy, taking into consideration the geopolitical uncertainty that affects donor flow. What steps should be... Sorry, Chair. What steps should the Minister of Health and Finance take during the 25-26 to champion and implement domestic funded multi-year transition energy? Should it be incorporated into the 2026 MTEF and 2026 METF and the 2026 DORA, accompanied by a formal progress report to Parliament? Thank you, Chair. Apologies about that, Chair.
No, thank you. The next one is Honorable Ryder.
Thank you very much, Acting Chair. Chair, I'm very concerned about this special appropriations bill, and I'm a little bit lost. On the 15th of October, Minister Ntreveni, the Minister in the Presidency, released a statement from Cabinet confirming that the US had agreed to a 6-month funding boost to bridge the withdrawal of the PEPFAR funding. Chairperson, this was also referenced in today's presentation. My concern is that bridging funding should certainly obviate the need for this bill, or alternatively, substantially reduce the quantum of this bill, and probably mean that the bill should be withdrawn, and we should be looking more towards merely an adjustment in the next couple of days. So I'm quite concerned. Should we even be discussing this bill is the question. Is it not time for this bill to be withdrawn? That's the first thing. The second thing that bothers me, Chair, and Mr. Singh has indicated that this money is coming from the National Revenue Fund. I pushed Treasury when they did the briefing to the department, to the committee, and I said, "Where's this money coming from? How are we able to suddenly appropriate additional funding? Has there been a tax collection boost? Are we taking money away from other departments in the adjustment budget? What's the actual source? How are we finding this extra money that we can spend when we know that there's so many conflicting demands on funding?" And the comment was that it's coming from the contingency reserve. That was the answer that Treasury gave me at our briefing. I don't believe that to be the case, and I think that if you are taking money out of the contingency reserve, there needs to be an actual documentary confirmation of that. Perhaps the FFC can just guide me about the processes that are involved. And at the same time, FFC, please tell us, if the US has given us this bridging funding, do the criteria required for a special appropriation still apply in this instance? And perhaps you can just confirm if those what those criteria for a special appropriation, what those criteria are. My last concern, Chairperson, is what's going to happen with this money. If we are appropriating money in terms of a special appropriation, emergency funds have been historically not well used in this country. And the reality is there's no clarity on whether this funding is to go to provinces, to the national department, to NGOs, or to what specific programs in terms of either the national department's estimates of national expenditure and annual performance plan, or if they are indeed provincial programs, or if it's merely to be granted and disbursements going to NGOs or elsewhere. We have no detail. That makes me incredibly uncomfortable, and it actually makes it impossible for us as a committee to have oversight over this special appropriation. If we don't know where it's going, then we can't follow the money. So I'm extremely concerned about that. Thank you very much, Chairperson. I would look forward to the responses.
No, thank you very much, Honorable Ryder. The next one is Honorable Ndlovu.
Thank you, Chair. And good morning to your good self and to all members and the community staff. Chair, I don't have much of questions. I want to ask just to check on the understanding. What are the medium-term risks to service continuity, given that 2/3 of the former donor-funded program remain unfunded? That's number one, Chair. And two, is how should Parliament distinguish capacity-driven understanding from donor disruption-related understanding to avoid misinterpreting departmental performance and undercutting justified funding needs? Thank you, Chairperson. I think I've got only those two questions. Thanks.
Thank you, Honorable Ndlovu. The next one is Honorable Swart.
Chairperson, good morning, and everyone, and thank you for the presentation. Chairperson, now just come back to, I think, the truth and the hard facts that Honourable Ryder has put to the table, and that is also my concern. Chairperson, just my input and 2 or 3 questions. I think we're not discussing, only a special appropriation. We are defending 20 years of progress in HIV and TB treatment. The withdrawal of donor support has exposed a structural dependency in our health system. This bill buys us time, yes, but time alone will not save lives unless, Honourable Chairperson, provinces have clear plans, ring-fenced funding and accountability to Parliament. Today we must be firm and no fund is absorbed into deficits, and frontline community services must be protected. Chairperson, this allocation must not disappear into provincial budget holes. We must require, firstly, clear provincial plans, ring-fence frontline funding and public reporting, and that is really concerning. And the questions, Honourable Chairperson, is that does the FFC believes wholeheartedly that provincial departments currently have the staffing and system capacity to absorb and utilize the 590 million rand effectively without delays or service disruptions in testing and tracing and treatment? And the second question, given the critical role of NGOs and community health workers previously supported by PEPFAR, what mechanisms would best ensure that this allocation reaches them directly instead of being consumed by general provincial pressures? And my last one, Honourable Chair, should Parliament require provinces to table costed HIV/TB continuity implementation plans before funds are released to prevent this allocation from being absorbed into general deficits? Thank you, Honourable Chairperson.
No, thank you very much, Honorable Swart. I think the last one is Honorable Machol.
Thank you, Acting Chair. Greetings to colleagues, and thanks to the FFC for the advices with regards to this special appropriation bill. Madam Chair, my comment will start by supporting the two interrelated recommendations, which are seeking to improve the efficiency of a domestic source allocation for HIV responses, and also to explore the PPP intervention in terms of resourcing the funds for the health program. Madam Chair, I'm saying that because relying or keep on relying on the external funding, Madam Chair, will disturb our program. I will zoom in what the presenter had said. He said the funds must follow the function. Madam Chair, as the presenter indicated, that I think there are some other processes that we missed before we engage into this appropriation. I think, as the presenter rightfully said, that we are a few days after the MTBPS. And then that process, Madam Chair, I believe it's influenced by the performance, the budget review and recommendation reports. We don't have that in our disposal to assess the performance of the entire health vote. Therefore, it makes us impossible to arrive at the reappropriation because we are not influenced by any performance which influence the function of what we are reappropriating to. Madam Chair, my other concern, I won't go to other comments that have been said by the other members, but the other one is with regards to the underperformance, in particular the NHI. I'm not sure whether the FFC will be in a position to advise us as to what are the reasons behind the NHI underspending reasons. Maybe one can have a sight as to why the NHI is below the spending. The last one, with regards to the source, I'm not sure whether I did get it clearly as the source of the 750 which will be breakdown into 3 sections. Maybe if one can get the clarity of the source of the 750, where will be the source of that fund? Thank you very much.
No, thank you very much, Honorable Majola, for the questions, and all the honorable members for having asked the question. Just to lower your hand so that we can continue. Can I, according to the program that I'm having here, it says we must allow stakeholders, because we do have a list of stakeholders who are going to be saying something based on the presentation from the FFC. So I need to be advised as to whether we are going straight to the public participation, or we allow the FFC to try to respond to some of the issues that have been raised by the honorable members. No, Dada?
Yes, thank you, Chair. Suggestion is that you proceed with the FFC engagement, and then once concluded, we move over to the public hearings.
Okay. So we start with the FFC to give us their responses.
That's correct.
Okay. No, thank you very much. Let's give the chance to the FFC to respond to what the honorable members have asked, and they want to be clarified on a lot of things. So we go straight to FFC to give us those responses. FFC, it's your time.
Thank you very much, Chair, and thank you to the honourable members for the questions. I should go through them in detail, but first I think it's just to assist Chair and the committee in terms of the protocols and procedures is that the stakeholders that you have, the list of them, it's not for them to make comments on our presentation. The focus, the center of the stage is the special appropriation bill that we're all making submissions to the committee to advise you. Honourable Chair, the Honourable Member Siwisa, you are absolutely spot on in terms of the concerns, your concerns regarding the capacity, capabilities, as well as the various existing, long-standing, some of them, issues with the health capacity and departments. The executive capacity, I would like to call it, and those performances and issues, the provincial legislature ought to have oversight of as well to assist the provincial executive. But at national, there's nothing preventing national parliaments or this esteemed committee to provide even more direct oversight of and to address some of these questions to the relevant executive branch, namely whether it be National Department of Health or, since it's a concurrent function, also Provincial Department of Health. But your take and your focus on and attention to the provincial capacity of health is it's crucial in this, in considering this this bill, and as well as other honourable members. I shall go through them. But your provincial specific of the Northern Cape case is very, very key here, because in terms of this health matter and issue of NHI, obviously it's a national issue, and it's a burden that we all share as a nation. Domestic multi-year financing strategy should it be incorporated into the MDPPS, MDEF? Absolutely. And this follows not just in terms of the Constitution, and as I said, in terms of the principles of the divisional revenue of Section 214 of the Constitution, equitable, efficient, and effective, but also in the PFMA. So we are now entering into even, as the money is now coming into the fold of our National Revenue Fund and the National Fiscus, we have to then apply compliance of a PFMA to it, even more stringently than just saying that, oh, here is a donor funding, and then because when it's a donor funding, there is some kind of relaxation in terms of in order to accommodate the use and the purpose of the fund by donors. Sometimes when the purposes are aligned with ours, national priorities, then sure, it's well to do. But when it comes to now the PFMA, it needs to come according to our processes of the budget process, and that includes, of course, the main budget, the medium-term budget policy statement, and that, as I said, it needs to then be the compliance requirements of the PFMA has to be fully applied. Honourable Ryder, your very first question is exactly the circumstances that also that we as Financial Fiscal Commission had a big issue on, is that now, as you saw, that on the just recently it said that PEPFAR will continue. Then why is this bill here? And in the same vein, this bill, as I introduced. Spoke of in the introduction, is that it's so alone, and that does not indicate any kind of fiscal confidence around in the transparency of this bill. And fine, but if your second question is that where this money comes from. It says it's contingency reserve. Contingency reserve, according to the May budget, the 3.0, it's 5 billion. But it didn't specifically say of its purpose or in its line items in terms of the budget allocation for particular programs and or purpose. I guess that is what contingency reserves are for. However, you pointed out as this, they should be contingency reserve should not be used in this way, right? Notwithstanding the facts, besides the point that actually PEPFAR will continue, then why are we then digging into our contingency reserve to I don't know, now creating more of a gap, I guess. In our fiscus and fiscal framework at that to accommodate this gap that no longer exists potentially. But another, I'd like to also commend that the question, the question that you asked about where this money comes from is exactly the right question with the allocative efficiency requirements that I spoke of, is that why was there ever the need and the why behind this bill, and also that and one of the questions is that should it not have been this amount of money be allocated within not just the fiscal framework, because that's what it's doing through contingency reserve, but also that between the votes. And because we have a national fiscal framework with functions allocated, hopefully well justified in all parts of that function, then why is there this, then we should be able to see clearly that we are shifting money from point A to this, or from C to this, instead of this sort of, well, we're just digging into our pot. And the process involved, Honourable Chair members, since we're so close to MDBPS, I think it also suggests that the discomfort from FFC fiscal transparency and governance point of view is that this bill so close to MDBPS, why then not just be part of the MDBPS? With all as Honourable Majola points out, then we would have more information on the performances, the functions, and then with the current spending thus far into this financial year of those programs and functions to inform our forward projections of the medium-term budgets. And so that process has to, as also Honorable Syriza said, it's supposed to, in good financial governance sense, it should have come together with NTPPS, following also with the medium term for the 3-year horizon allocations, and saying what that should be in terms of our allocations and what are the plans developed around National Treasury and Minister of Finance to accommodate such. Now, what is going to happen to this money? I think it is not just about where, which you, Honourable Member, you said it right, but also, as I said, it's how is it going? That is not very clear to us, because it's also the same way that we are thinking about that this special appropriation bill, and because it has implications for the provinces, why should it not be, and I think it ought to be, if we are still proceeding with the special appropriation bill, that it needs to appear in the divisional revenue bill. And when do we table that, or National Treasury should table that? It's with the medium-term budget policy statement, with the divisional revenue bill amendment. And as well as don't forget, there is also the appropriation adjustment bill. So it's all done in very, very questionable circumstances and with its very questionable intentions, actually, may I say so, for the special appropriation bill. This bill is very singular, it's narrow, it's very lonely, actually, and then that it doesn't fulfill all the legislative requirements and good principles of divisional revenue. That is to summarize it up. What should the Parliament address the capacity issues, as I said by Honourable Ndlovu, is that, as I said, it's not just the provincial legislature, but the national, or shall I put it the other way, is that it's not just that this committee ought to be concerned itself with this special appropriation bill, but also the provincial legislature. And in terms of capacity, I think National Parliament, or this NCOP as a select committee, is much better capacitated to address this issue. So you are right on in terms of this question. To take it, to even scrutinize and examine more, put the provincial departments and the national departments under scrutiny on this matter. Honourable Swart, your question about I agree with you. It is about safeguarding the achievements on preventing or the spread with the spread of HIV, of the disease. Now, the question is, though, provincial plans. We don't believe, as it's informed and verified with other analysis that we have provided, that that provinces have the capacity. And also, we don't not just say that, but we actually showed that also at the national level, we have questions about that the capacity and the performances historically to implement. And these are supposedly, it's not that we haven't given time. It's actually decades for this implementation on various big projects that is related to this particular funding of PEPFAR and other, for instance, like NHI and other programs of this nature. And the problem of sending money directly to NGOs, unfortunately, Honourable Chair Members, as you noticed, is that we would lose the little control that we have through the procurement system to oversee and control the NGOs to ensure that the funds are being used effectively. I'm sure that we all know that this sector has long been mired in also various corruption activities, the Tembisa Hospital and this hospital and that hospital, and the NGOs. And then the question is also where does the provincial legislature, the oversight bodies should have come into to ensure that the money is being used effectively. The transfer ultimately itself, I want to actually put it like that, is that transfer itself is actually not the issue in South Africa. Right? Money does not have a problem about getting to where it needs to get to. The problem now actually is about that along the way, there are people and or systems that are just not implementing with the money that they get. And so it's not number one. It's not that a lack of funds, and it's not as you often we hear when it comes to appropriations. But it's also not about transfers. The money did not have a problem about getting there to where it's supposed to go. It's now the spenders, the users, the implementers that is not implementing. And sometimes when the capacity just cannot, or the implementers just cannot implement, the first go-to solution is not to give it more money. It's actually to see, as honorable chair members you have pointed out, is that we need to figure out what is not working. Do they have the staff? Do they have the right staff? Do they have the know-hows, the process, the plans? And by the way, plans are just plans until it actually has the performances that can justify that, yes, we have the activities related or well-aligned in order to implement this. I think I want to end with Honorable Majola's last point, which is quite clear. Yes, the source of the clarity of the source of funds is not clear. I think and not just that, but also the uses of the funds is not clear. And along with it is the whole legislative matters of it, as I said. And so it's a very, very problematic bill on its own. And that I think perhaps its final advice is to hold off this appropriation bill and compare this with either say put it back to Minister of Finance to retable it with the medium-term budget policy statement, and we need to then see that this special appropriation bill is well deliberated and incorporated into the broader fiscal framework and the broader budgets, that is the medium-term budget policy statement with all the justifications of the mid-year adjustments to the allocations, then we can consider again. Alternatively, wait with this special appropriation bill still on the table, with the consultations and so forth, and then for the medium-term budget policy to come out with the relevant divisional revenue amendments and the adjustment appropriation bills, and we then see if there are alignments. And by that time, honorable chair members, you can rely on us, Financial and Fiscal Commission, will be there to do that assessment and advise you accordingly. Thank you, Chair.
Thank you very much, FFC. I don't know if ever your colleagues have got something to add on what you have tried to respond on. Are they fine, or they want to add something?
Chair, I think we are covered on our side. Thank you, Chair.
Thank you very much. With the responses, it's clear and well understood. What we can do now is to take our stakeholders with us so that they can give us their views on what is going to happen on the issue of the FFC. So we want to allow our stakeholders with a time limit of 10 minutes each stakeholder. It mustn't overlap. Maybe it can overlap by 2 minutes, but we want to respect the time. We are starting with the first stakeholder, which is Breadline, to give us their view on the matter that is on the table. So we will allow the Breadline to take us through their issues, and also to tackle whatever that they feel it must be corrected. So without any waste of time, I will give Breadline this opportunity to take us through their presentation. Breadline, it's your time.
Thank you, Chair. I'm just sharing a screen. Please let me know if you can see it. Can you see my screen?
Yes, Warren, we can see your screen. Thank you.
Thanks, Chair. Thanks, honourable members. I just want to start by saying I couldn't agree more with Honourable Swart and Mr. Tang about NPOs and NGOs being the backbone of service delivery. And the concerns raised about funds coming directly to us is the one aspect where I agree. I think it should go directly to NGOs. It's also then the concern about which NGOs are trustworthy. So I just want to give a bit of context on who we are. Breadline Africa, infrastructure focused on ECDs, over 2,500 structures or units built over the 32 years of existence. Serving over 350,000 children. We are actively implementing in the just energy transition zones with the Office of the Presidency, the PCC, DBE, and local municipalities in Mpumalanga. So the Chair would be very interested to know that we are trying our best in her province. Utilizing tools like the Learning Programs Quality Assessment, as well as green light assessments for impact measurement. So why does it matter now? It's the withdrawal of international donor funding is obviously going to expose some vulnerabilities. And the bill offers strategic inflection point to build resilient integrated systems. I just want to reiterate the withdrawal of international donors. Yes, their withdrawal has majorly affected health and HIV services. But indirectly, organizations like myself and others are losing these donors because someone now needs to cover that international loss. So our local donors have shifted. So our donors have now pulled out of funding from education in early childhood, which is obviously a massive effect for the country. I just want to use some basic findings that we did earlier or a few months ago in Komati, just outside Middelburg, where one of the power plants has been decommissioned. So the field data shows that almost 60% of children arrive hungry. 46% don't have transport to get to healthcare, because in these small towns, as an example, there are no clinics. They need to make their way to Middelburg. 55% struggle with mental health, and 84% don't have ID books, which means they won't have access, especially with the situation at local government institutions where South Africans are, well, blocking foreign nationals from entering. And if you don't have an ID book, you can't prove that you're South African. Infrastructure deficits, so 75% of the ECD centers lack compliancy. No toilets, no hand washing, no safe water or kitchen, as well as the outdoor play areas. All of these affect health to an extent. So ECDs are not just learning spaces. These are potential health assets. We can track stunting, we can track vaccines of the children early on, nutrition delivery sites, identification for developmental delays, and community health education platforms. So this is just from one community, and as an example based on facts we have, but wherever we've been throughout the country, this is almost a standard. The Thrive by 5 numbers have come out, and stunting is a major concern. Fine motor skills are a major concern for children under 5 years old. And then not to go into the education side of things, where 60% of children are falling behind or are behind, according to their peers. We've got a few proposals using Komati as a potential pilot, building a ECD hub, 200 child capacity hub with a mobile medical clinic, daily feeding, and covering all the components of the nurturing care framework, as well as obviously data measurement and quarterly assessments. What is the return on investment is there are a number of jet sites that are going to be decommissioned in the near future, where these towns are going to be forgotten, and we're going to have ghost towns with people living there with no services, no access to health and education. So we can roll this out throughout the province, and Mpumalanga in particular. Our second proposal is ring fencing 1% of the amended revenue to the municipal infrastructure grant to ECD infrastructure. This is obviously a massive issue with the Banapele mass registration drive, where these ECDs are bronze now. They need to get to silver and gold before they can actually get a subsidy of that 24 rand a day per child. So if we could look at allocating potentially 500 million a year towards ECD infrastructure, this enables registration of thousands of centers, which then gives subsidies to these children in need. And if we focus on Mpumalanga, we can focus on these jet-affected municipalities. Our third proposal is multi-sectoral appropriations. So pilot this 20 million project with the DOH, DBE, and DSD. Shared planning, joint indicators, and pooled budgets. As an NPO, we do raise funds, so we're not here to beg for money. We're begging for public-private partnership. We're begging to work together. That's what we want to do. We can raise funds, but we need to be matched somewhere. And then hopefully an amendment on Section 38. So what do we offer? Well, we've got the expertise in infrastructure. We've field tested the data in just this particular area, but across the country, we've got results. Let's focus on the jet zones. We've already built up partnerships with Soweto Institute, Kids Collab, Genesis Analytics, Equality Collective, Lifa Labantwana, and these are just in this area. We have, I want to say, almost 40 other partners that we work with across the country. So next steps, we ask for an invitation to present a detailed costing and implementation plan, especially for this Komati project, engagement with National Treasury on ring fencing mechanisms and collaboration. That is our biggest ask, is can we collaborate? Not just on this project, but on a national rollout of other projects. An additional 50 to 80 million across these proposals would catalyze South Africa. It would help our young children. So on that, I just wanted to say thank you for the time, and I appreciate the opportunity to share with you. Thank you, everyone.
No, thank you very much, Warren, for the presentation. We are continuing with our stakeholders. So the next stakeholder to present is the Rural Health Advocacy Project. I see their names there, Celine, Russell, and Hanifa. Candice, I don't know who's going to present, but one of you, we are waiting for you to get the presentation.
Good morning. It's going to be me, Hanifa Mahlangu. I'll be representing the Rural Health Advocacy Project. Thank you. Are you guys able to see my screen? Am I audible?
Yes, Hanifa, you're audible. Please go ahead.
You are.
Okay.
You are audible. Yeah.
Thank you. So So greetings to everyone. Thank you so much for giving me the opportunity to speak today. My name is Hanifa Mashangu, and I'm a research assistant at the Rural Health Advocacy Project. We are a division which is associated with the Wits Health Consortium, and we seek to promote fair and equal access to quality healthcare for rural communities throughout the South African region. Today, I come before you not just to... My slides are not moving. Okay, today I come before you not just to discuss the figures in a budget, but the lives that depend on them. In South Africa, healthcare is not just a privilege. It is actually a right that is given to us by our constitution, because Section 27 of the constitution makes it very clear that everyone has the right to access healthcare, healthcare services, and that the state must take reasonable steps to make this a reality. So the Special Appropriation Bill and the 754 million injection into the health budget is a step into the right direction. However, we must be very honest, the money is not enough. Most of the money will go towards salary increases and inflation adjustments, leaving very little for the real challenges facing our communities. And so the question is not only how much we spend, but how we spend it and who benefits from it. So basically, we're going to be needing a plan because many provinces are already struggling to stay afloat. These provinces carry large debts, unpaid suppliers, and shortages of essential medicines and staff. So the withdrawal of the United States government funding, which supported our HIV and TB programs, has also made things even much more worse. Because according to the SANEC Civil Society Forum, nearly 24,000 health workers across the country were affected, and 97% of them are working in public clinics and public hospitals. Most of them are lay counselors, lay nurses, and data capturers who form the backbone of our HIV and TB response. So if these posts are lost, the gains of the past 2 decades will basically be undone. And the hardest hits occurs in rural provinces like KwaZulu-Natal, Eastern Cape, Northwest, and Limpopo. These areas are already struggling to attract and retain staff, and losing these workers will basically push them even further behind. But beyond filling these gaps by the donor that were left by the donor withdrawal, we must also take this moment to focus on the core priorities that hold our health system together. These are areas where every single rand makes a very big difference and it counts. So if we want this bill to deliver a lasting impact, we must ensure that it supports the foundations of our health system in South Africa through protecting young mothers and young people, tackling the growth of the burden of non-communicable diseases, and fighting against TB. So looking into maternal and adolescent health, in our rural areas, young girls face very serious risks like early pregnancy, lack of information on health services, stigma, and very much limited access to sexual and reproductive health and antenatal care. The Rural Health Advocacy Project produced a policy brief this year in June, which was named Putting the Youth First. And in this policy brief, we found that the pregnancy rates are highest in rural provinces like Eastern Cape, where it's at 18%, and Northern Cape, where it's at 17%. And in addition to this, antenatal coverage remains below 70% in most rural provinces. And these numbers are not just statistics, they are actually young lives facing futures that are cut short. So when counselors and nurses are retrenched, who will provide family planning and guidance and care for these young girls that need the health system? So without enough support, more rural young women and girls will face complications in pregnancy and childbirth, and more young people will lose the chance to plan for their futures. Looking into non-communicable diseases, so beyond our HIV and TB, South Africa, and especially in rural areas, we are facing a growing crisis in NCDs, especially in diabetes, high blood pressure, and other chronic diseases. We once released a diabetes fact sheet in late 2023, and in this fact sheet, we found that Limpopo showed that it has one of the highest rates of new diabetic cases, even though Limpopo only contributes 10% to our national population. Additionally, rural women's blood sugar levels are almost 4 times higher than those living in cities. These conditions demand early detection and long-term management. However, rural communities and clinics often run short of medications and staff, and this is still happening. So if funding is not protected for these services in these areas, the NCD crisis will quietly deepen, straining families and communities that are already struggling. And we cannot ignore the fact that TB and HIV remain deeply entrenched in South Africa, especially in our rural areas, because in some districts, HIV prevalence is close to 28%, which is way above the national average. Provinces like Eastern Cape and KwaZulu-Natal, they bear the heaviest burden, but they receive only a fraction of the donor support. So with the PEPFAR withdrawal, PEPFAR funding withdrawal, we are already seeing the consequences of this, which are sometimes fewer HIV tests and a sharp decline in the ART initiations throughout the year. So the data also suggests that if nothing changes, new adult HIV infections could rise by nearly 30% just from 2025 to 2028. This is just a span of 3 years. And we cannot let this happen, because losing health workers now means that we're also losing lives tomorrow. So every counselor and nurse we fail to retain represents a person who may not get tested, treated, or supported. So as the Rural Health Advocacy Project, we came together with some recommendations that go beyond the budget increases, but focus a lot on real prioritization. Firstly, we recommend that there should be a ring-fence part of this allocation for rural primary health services and for keeping frontline workers employed. Secondly, there must be an institutionalization of rural proofing to make sure that every health budget decision is tested for its impact on rural communities. This is because every health budget decision should ask one question: What does this money increase mean for rural areas? Thirdly, we recommend that there should be a requirement of provinces to report monthly on how they are sustaining HIV, TB, and NCD services, including workforce retention. These reports should show how provinces plan to maintain and transition HIV, TB, and NCD services. They must explain how funds are used, how staff is retained, and how services are performing. This will help the national level to monitor and respond before problems get worse. We also recommend that there should be an absorption of the PEPFAR-funded health workers into the public health system to prevent services from collapsing, because these are skilled workers who know their communities and play a vital role in service delivery. And lastly, we also recommend that there should be a strengthening of accountability whereby the Treasury, the National Department of Health, and the Parliament work together to monitor how funds are reaching the ground. So in closing, rural healthcare cannot improve through budget increases alone. What matters most is how that money is used and whether it reaches the people who need it the most. Real progress means holding provinces accountable for fair and transparent spending. It means protecting key health programs and supporting the rural workforce. So if we are very serious about building a fair health system, we must start with rural communities, because each decision we make should move us closer to a South Africa where every person, no matter where they live, can access quality healthcare and live with dignity. Thank you so much.
No, thank you very much for the presentation. I'm glad we are sticking to the timeline. So I think we must just follow like that, and we mustn't remind someone that your time is up. We are going to the next one, which is the TB Accountability Consortium. There's a name, Sinhle Mahonga, who's going to take us through his report. Sinhle?
Thank you so much, Honorable Chair, and a very good morning to everyone. I'd like to share my screen.
Okay.
If you're ready, you can go, Celine. Thank you.
Thank you so much, honourable members. I am actually joining from a colleague's device due to technical difficulties. My apologies. My name is Sihle Mahonga, and thank you for the opportunity to present on behalf of the TB Accountability Consortium. TBAC is a civil society platform working to strengthen the transparency and accountability around our nation's TB response. And so our message today is simple. No provincial plan, no progress. We ask that you protect
You've muted yourself, ma'am.
Hello, I think we have muted yourself.
Yes, Honourable Chair. My apologies. Our message today is simple. No provincial plan, no progress. Money cannot save lives if there is no plan for how it is spent. Parliament's allocation through the Special Appropriations Bill is indeed a welcome step. But unless provinces clearly show how these funds support TB, HIV, and community health programs, the system will remain on life support. Because two things stand. The biggest threat to recovery is opacity, and not a shortage of funds. Chairperson, the fiscal context to which the bill arrives is of great concern to us. Provinces collectively carry around 22 billion in accruals, with all reporting major shortfalls. Treasury's new Targeted and Responsible Savings Framework, or TARS, compels provinces to cut or to reprioritize low-performing programs. But yet what we see at facility level, those savings often mean fewer nurses, it means fewer community health workers, and less TB tracing and treatment provision. The graph to your right illustrates the provincial accrual debt, showing how two of the three provinces, KwaZulu-Natal and the Eastern Cape, carrying the largest burdens. These two provinces, which are also rural provinces, bear the highest TB caseloads. So the areas of greatest financial strain overlap directly with the areas of greatest health need. And the Special Appropriations Bill requires monthly reporting to Treasury, but yet there is none to Parliament or to the public. And this leaves major blind spots in the oversight, and it undermines public trust. That without clear public accountability, health budgets risk being absorbed into existing deficits, and instead of protecting frontline services and TB and HIV care. So the End TB campaign within the National TB Recovery Plan, and this forms, part of the National Strategic Interventions for TB, has a set target of testing 5 million people by 2026. But yet, this current budget allocations can only cover 3 of the 5 million tests. This leaves a gap of 2 million people who are undiagnosed, who are untreated, and potentially infectious. Provinces have not detailed explicitly how they will scale up testing, diagnosis, and care linkage, nor how they will integrate TB recovery into the broader district health platform. Sustainability plans exist on paper, yes, we know, but without provincial reporting, there's no way to know whether they're being implemented. And if we continue without transparency, we risk quietly undoing 20 years of TB progress, just as the recovery is within our reach. So accountability begins with transparency, and this Appropriations Committee can bridge the gap between fiscal measures and real health outcomes by using Parliament, not only Treasury, as oversight for how this money is used. And so therefore we recommend these 3 urgent measures. Firstly, provinces must present detailed health financing and implementation plans to Parliament, showing how this allocation supports TB, HIV, and community systems. Secondly, quarterly provincial reporting to both the standing committees of health and appropriations should be made mandatory. And thirdly, a joint sitting on Health, Finance and Appropriations committees should be convened to treat the health funding crisis as a matter of national urgency. These 3 steps would not add bureaucracy. They would actually close the accountability gap and restore public confidence that funds are used where lives are at stake. Because transparency is not punishment. It is, in fact, a bridge between national intent and local delivery. And Chairperson, this bridge has never been more critical, especially as our nation enters the PEPFAR bridge plan period. So, honourable members, keep the promise. The PEPFAR bridge plan marks a turning point in global health financing, and it signals a shift from externally driven programs towards greater domestic stewardship and sustainability. And this transition brings opportunity, and it also brings risk. It offers the chance to embed local accountability, but it also exposes the fragility to provincial systems if oversights remain weak. This special appropriations bill, as well as the bridge plan, are in fact 2 sides of the same coin, and they actually indeed ask a critical question. Can South Africa sustain its national response once external funds transition domestically? And the answer depends on transparency. If provinces do not publicly account for how health funds are used, the bridge plan will become a bridge to nowhere. A symbolic transition without real certainty and substance. And the TB Accountability Consortium stands ready to support Parliament and the National Department of Health with evidence-based tools, as we understand that this is a partnership between civil society and those who are duty bearers. But oversight must start here in Parliament. And without visibility, TB, HIV, and community systems will continue to deteriorate, even as NHI reforms advance. Provinces must not fail the people that they serve, and Parliament need not look away. 56,000 South Africans die of TB every year, not because of medical failure, but because of governance failure. Accountability is not just simply bureaucracy, it is continuity, and it is indeed life-saving. And so in closing, Chairperson and honourable members, this bill is more than a fiscal adjustment. It is, in fact, a moral test, and the bridge plan challenges us to carry forward what international partners began by proving that domestic accountability can sustain global gains. The bill, therefore, is not just about numbers. It is about whether those numbers can translate into lives saved, services delivered, and systems strengthened. And if Parliament demands transparency from provinces today, you will not only protect the TB response, you will set the foundation for a sustainable, sovereign, and accountable health system. Accountability saves lives, honourable members, and it secures the bridge to sustainability. I thank you.
No, thank you very much, Cynthia, for the presentation on TB Accountability Consortium. The next stakeholder who's going to present for us is Mduduzi Nkosi, who's representing Section 27.
Thank you, Chairperson. Good morning to the honorable members. My name is Mduduzi Nkosi, and I'll be presenting on behalf of Section 27 and the Treatment Action Campaign. So by way of introduction, a bit about who we are as Section 27 and the Treatment Action Campaign. So Section 27 is a public interest law center that seeks to build capable and working healthcare and education systems that work for all South Africans. And the Treatment Action Campaign is a civil society organization that aims to advocate for a working, unified healthcare system that offers quality and dignified access for people, especially people living with HIV and TB. So on to the Special Appropriation Bill. Section 27 in the TAC welcomes the Special Appropriations Bill as an agent intervention to prevent the disruption of important HIV and TB services for many South Africans. However, as the other presenters have noted, the FFC specifically, this bill is only a short-term fix and fails to address more profound structural weaknesses that are evident in the South African healthcare system and how we finance healthcare. And this bill should be understood in the context where we've had years of austerity, real-term budget cuts, rising provincial debts, which other presenters have spoken about, which mainly have come in the form of accruals and unpaid invoices, and unpaid personnel that has eroded capacity to deliver quality services in the healthcare sector. So within this context, you must understand that this bill is just a financial pledge, and that we should do more to rescue what we see as a fragile health system that's overly reliant on donors for constitutionally mandated healthcare services. Honorable members and chairperson, we have seen what the impact of deficient healthcare funding can do for human rights and human lives. In 2008, ARV dispensing was halted in the Free State due to budget shortfalls. And in that case, an estimated 30 people are estimated to have died each day due to the inaccess to life-saving medications. The same risk exists today if this bill and other plans to bridge PEPFAR funding are not equitable and enough to cover the need for education. So we are saying that funding shortfalls in the healthcare sector will undoubtedly lead to direct human consequences. In terms of the budget, one of the things that we'd like to note is that there's been a lot of cuts in the overall healthcare budget in recent years, and for HIV specifically. In 2013, Treasury introduced one of the harshest cost containment or austerity measures that we've seen in recent years, where 1 billion rand was cut from the HIV and AIDS care budget. The argument there was that there were savings that were realized due to a lower cost of procuring antiretroviral therapy and a noted decline in the uptake of medications. A further 1.3 billion per year reduction was proposed in the same budget over the MTF period. We were saying that these are funds that ought to be brought back and reinvested into expanding testing and treatment retention for people living with HIV, and that they could go a long way in helping bridge the gap left by the withdrawal of donor funding. On PEPFAR's contribution to our HIV response budget, we see that last year in 2024, PEPFAR contributed roughly 17% of South Africa's total health response, which translates to about 5.8 billion rand in rand terms. However, the Special Appropriation Bill allocates only 754 million rands of that, in addition to the announced PEPFAR bridge plan, which has a total allocation of 2 billion rands. Simple arithmetic, Honorable Chairperson, shows that this amount that's been appropriated in the special bill and the PEPFAR bridge plan is not enough to cover the full cost, the gap left by the withdrawal of PEPFAR funding. And therefore, we argue that there needs to be additional funding, including a multi-year, multi-billion rand, multi-year plan to cover the gap left by the withdrawal of PEPFAR funding. A significant number of HIV patients who relied on PEPFAR funding are at a great risk of losing access to medication if the gap that I've already spoken about is not adequately filled. Therefore, we believe there needs to be a concrete and workable plan for absorbing, for the domestic absorption of previously donor-funded programs that would include staff, that is community healthcare workers, commodities, which is medicine, and systems that were funded through PEPFAR. Honorable Chairperson, another issue that should be noted by this committee with the bill is that provinces are under severe financial strain and operational pressures. And the funds for HIV programs that are allocated in this bill are at risk of being swallowed up by existing debt and expenditure priorities if the money is not just ring-fenced specifically for HIV response programs. There are some examples of these pressures and operational challenges that we've seen, including community health care workers not being paid in Mpumalanga. There are massive infrastructure backlogs and medical legal liabilities in the Eastern Cape, and of course, there's been the recent cases of corruption and procurement failures in the Gauteng, with Tembisa Hospital being the more recent example that comes to mind. The same provinces also have issues with high vacancy rates, with chain supply management and poor accountability systems. That will definitely undermine the ability of this bill and the money allocated to this bill to reach its recipients and provide much needed care to people. With this in mind, the Section 27 and the TAC therefore argues that the money in the bill should include conditional spending guidelines for the funds to protect it for frontline services and ensure that the money is spent where it should be. On the impact of the withdrawal of PEPFAR funding, Chairperson and honorable members, we've seen that since the withdrawal of the funding, there's been a marked decline in HIV testing and adherence support for many people in parts of the country. We've also seen an increase in the number of one-month ARV refills and a decline in three-month refills, especially in the Northwestern Limpopo, which is of concern. We've also seen reports of longer wait times for patients. Some places have also reported medication stockouts. There's been reduced staff morale and the overall poor patient experiences. All these developments put together reflect a system that is under strain and at the risk of backsliding on our way to meet our 95 targets. Regarding the funding to the South African Medical Research Council, which is an integral part of our HIV response program, we do welcome the 132 million rands that's been allocated to the council. However, this amount is below its estimated 200 million rand allocation that the organization the council needs to function properly. We know that the council is in charge of HIV research and informing our HIV response strategy. And the brilliant consortium's HIV vaccine research that's part of the council was delayed due to donor withdrawals, risking scientific progress and researcher retention. To avoid these issues, we believe that Parliament should ensure that there's a multi-year predictable funding plan for the council to safeguard our research capacity for HIV and TB, and to avoid our over-reliance on external donors. Honorable members and Chairperson would like to take this moment to again bring up an issue that's very important in South African public policy and finance, which is our gender-responsive budgeting efforts. And in this case, we would like to note that the HIV epidemic in South Africa has been highly gendered. We've seen that young Black women specifically, and girls are disproportionately affected by the HIV epidemic, and that the healthcare center is one of the largest employers of women in the country. especially for healthcare, community healthcare workers and nurses. And many of these posts were funded through PEFA. And that with the withdrawal of donor funding, we run the risk of many women losing jobs and further entrenching our already high unemployment and gender equality. So to end, Chairperson, these are our recommendations for this bill and HIV and our HIV response in general. We are calling for a strengthening of transparency and reporting. We believe that Parliament should use the opportunity of this bill to ensure that there's publicly accessible, accurate, and disaggregated reporting on provincial spending and performance specifically for the HIV program. Would like to see a case where donor-funded programs are integrated into the domestic budget by 2026-27, as this would ensure that there's stability in the system and that people are not at risk of losing healthcare due to external developments. As mentioned earlier, we'd like for the funds in the bill to be ring-fenced specifically for frontline services, and that no diversion should be made using the funds to pay for other priorities in provincial budgets. And the next one, which I've already spoken to, is the introduction of a multi-year funding plan for the South African Medical Research Council, which would help stabilize the organization and its work in researching HIV care. And would like to call for an expansion of Treasury's gender responsive budgeting program to include the healthcare sector, as it is one of the departments that's highly affected by gender, and gender responsive budgeting would go a long way to improve the state of affairs in that field sector. And we're also calling for restoration of the 2.3 billion rand that's been cut over the past years to the HIV program. And lastly, we'd like to call for Parliament to ensure that Treasury and the Health Department build a predictable, equitable, and working healthcare financing framework that reduces donor dependency and protects access to healthcare for all. I think this is the end of my presentation. Thank you, Chairperson. I'll turn back over to you.
Thank you very much, Section 27. We move to the next stakeholders to present to us is Institute for Race Relation. The name is Mr. Gabriel. Take us through your report.
Greetings, Acting Chairperson. Thank you very much for the time and opportunity. I would just like to start by saying I am representing IRR Legal. The Institute of Race Relations is a member of IRR Legal, but it is a different organization. This submission is by IRR Legal, not the Institute of Race Relations. Thank you again for the time. So we're going to talk about the Special Appropriations Bill, and we've got a very simple recommendation, which is to make that which is implicit explicit, that there are no BEE premiums in this bill. Of course, given what you've heard here today, it would be no surprise if the committee was to send back the bill and say that due to its legal flaws, it can't be passed at all. But if you do go ahead with this bill, we suggest that you at least make that clear. Agenda, first we're going to ask, are BEE premiums goods and services or subsidies? The committee will be familiar, I think, with this, but we'll just go over it for a refresh. There's 750 million odd rand breakdown into goods and services versus transfers and subsidies. We will go through that and find that there are no BEE premiums in either the goods and services or the transfers and subsidies split. As a result, we say, just make it explicit. It's already implicit that there's no BEE premiums. Make it explicit to avoid confusion. We will show why that is a constitutional compliance issue and a popular opinion issue too, given that this is a popular representative body. We don't just want to give our own opinions. What is a BEE premium? Everyone here already knows it. The definition is provided in the current Procurement Framework Act. and the incoming one. The committee is very well aware. Chief Procurement Officer Willie Machibula said capped at 25%. It's very easy to calculate that. So I'll go through this. Everyone already knows it. We've also already shown the study from the late Professor Stephen Mejero, which found BE premiums in one particular department averaging at 20%, although sometimes going up as much as 61%. This was done a while ago. There hasn't been much subsequent study. That's unfortunate. Okay, so we know what a BE premium is. It's paying more for less in order to achieve BE goal. Are they goods and services or subsidies? Well, in passing the Appropriation Bill at the time, now Act of 2025, there was a back and forth in front of this committee and elsewhere on this question. The basic position is that the Appropriations Act defines payments, the subsidies versus goods and services split in terms of the guidelines from 2009, the format, and that format defines transfers and subsidies as unrequited payments. A payment is requited, this is quoting, when the government gets something directly in return of similar value. So you give some money, you pay some money, and you get back a laptop or a wheelie bin or some medicine or services from an administrator or a doctor or an insurer. It's unrequited when you pay and you don't get something directly back in return. And so if you're paying extra for a doctor or medicine or laptop or administrator or whatever in order to pursue BEE, you're not getting something back in return for that directly. Look at that word directly. You're getting something more broadly, a policy goal of the government. And the policy goal in various forms is pursued through unrequited payments called subsidies. A subsidy under the format may be a specific amount of money per unit of quality of good or service, may be calculated ad valorem. It may also be calculated as the difference between the target price and the market price paid by the buyer. And this is all to say that under these are quotes from the format guidelines. If you're paying a specific amount, if you're paying 500 Rand for a broomstick, and you're paying all that extra because you like the broomstick seller, they plant their own trees, and you think that suits a policy objective to do with planting trees, so you're willing to spend an extra 450 Rand per broomstick. That's fine as a subsidy in principle, and there's no problem even though you're only paying one amount, 500 Rand. You're not in the payment saying, look, 450 is for the subsidy, 50 is for the broomstick. Because of the breakdown. It can be ad valorem, it can be per unit, it can be as the target price difference. So the way BE premiums works, it makes sense to classify them as subsidies under that definition from the format. Treasury has given a different opinion. It says that money paid for BE premiums is not a transfer, nor is it a subsidy. Rather, Treasury claims that BE premiums are goods and services. In other words, people's race is a good and a service. If you pay extra for a person based on their race, that you're actually getting a different good or service. We disagree with that, but they have said BE premiums are included in the cost of goods and services, therefore classified as such. We've said why that fails to recognize the format guidelines. But that's Treasury's opinion, and we want to report it to you because obviously it's relevant to the tabling and processing and understanding of this bill that stands before this committee at this time. So we've got 750 million odd Rand. Here's the schedule in the bill, and you can see neatly that it's broken down into 32 million, that's for goods and services, and 722 million, that's for transfers and subsidies. So a lot of the focus of today has been where's the money coming from. We want to focus on where's it going to, and there's that 32 versus 722 split at the headline level. The 32 million goods and services, 722 million transfers and subsidies. Where are the BE premiums, if anywhere? There's no BE premiums and transfers and subsidies. There can be no BE premiums and transfers and subsidies because Treasury said that BE premiums are included in the cost of goods and services and therefore classified as goods and services. So they can't be classifying it as this here. Well, either Treasury changed its mind or it hasn't about how appropriating funds from the fisc works. It hasn't changed its mind. If it had, it would have said so. So we can conclude that this bill does not include any BE premiums under transfers and subsidies, notwithstanding our own arguments and our own submissions. Treasury hasn't changed its mind, so they can't be there. No BE premiums under transfers and subsidies. 722 million Rand there, zero for BE premiums. Simple as that. Okay, what about goods and services? Treasury said in principle, BE premiums can go to goods and services. But under this bill, it says that the goods and services are for NHI indirect grant, specifically a health systems component, that 32 million. And it says what the purpose is of that is. I showed you the thing in an earlier slide. I'll just read it out loud for you. Achieve universal health coverage by improving the quality and coverage of health services through the development and implementation of policies and health financing reforms. So the purpose there is universal health coverage through quality and coverage depth. Okay? That does not include BEE premiums. The Zono report warns us against pretending that BEE purpose and value for money purposes are the same things. Go back to the broomstick, go back to the medicine. If you're spending extra for the same thing, that's a subsidy. You're doing BEE premium stuff. That may be allowed under the current legislation. It's clearly allowed under the triple PFA. But that is distinct from the value for money purpose, which in this case is universal health coverage. And the Zono report said, don't confuse the one with the other. Be very clear, be transparent about the difference between the service provision that is supposed to come through the procurement and the extra policy purpose, like localization is another one. It's not all about rest. It can be localization, can be a green agenda, can be any different kind of purpose. He said, don't confuse those two things. So if we're not confusing those two things, clearly the only purpose here is universal health coverage. That means there's zero for BEE premiums out of that 32 million. There's also zero out of the 722 million on the transfers and subsidies. That means there's zero out of the 754.527 million. Zero for BEE premiums, 754 million for the rest that is actually tabled in the bill. So we say, make explicit that which is implicit. It's already implicit that there's zero for BEE premiums. Just make it explicit through the language. Section 1.4 suggested amendment. No money to pay for preference premiums are provided under Section 2 of the Public Procurement Policy Framework Act is appropriated from the National Revenue Fund in this Act. You do that, and you'll avoid confusion. Why do we want to avoid confusion? Well, for constitutional compliance. We've already said there's a bit of a, Treasury's got one idea, Constitution's got another idea. Clearly under Treasury's idea, there's no premiums going through here, but it can get confused. So let's just go over how this actually works. We've got the Revenue Fund, which is where the money sits. You've got withdrawals from that to organ of state. I'm using that phrase loosely, as the Constitution sometimes does. Organs of state then contract out to the private sector, and that's where the rubber hits the road, so to speak, in terms of finances. And the withdrawal side is governed by Section 213 of the Constitution, and the contract side is governed by 217 of the Constitution. And that can sometimes cause people to be a little bit confused, but it's actually quite simple. Let's just zoom in on the contract side. The contract side, there's an organ of state that does a contract with the private sector. If it's a requited payment, the government pays, it gets goods and services in return. But the government can also do unrequited payments, subsidies. That can be literally in the form of grants where you're giving out money, or it can be in the form of payments that go over and above the goods and services that you're getting in return. Okay, so that's one side of things. On the other side of things, you have the National Revenue Fund withdrawals to the organ of state to do that. And there has to be transparency about whether those withdrawals are going to requited payments or to unrequited payments. Because if it's going to requited payments, there's an expectation that there's goods and services in return. If it's going to unrequited payments, there's an expectation that there's broader social policy agendas that's being pursued. This requirement that at the point of withdrawal, you distinguish between requited and unrequited payments falls out of the Constitution. Partly Section 213.2, which says withdrawals must be made as an appropriation or a direct charge. And partly out of Section 217.1, which says the system of procurement must be transparent, and partly out of Section 216, which says that the legislation around Treasury must ensure both transparency and cost management. You're not doing cost management if you're not at the point of withdrawal stipulating whether it's going to be a requited or unrequited payment. Now, since the new Rainbow Republic's new constitution in 1996, and certainly since the framework was established in 2000, requited and unrequited payments have always been distinguished at the point of withdrawal. That is the current system. That is in this very bill. It shows that difference between requited and unrequited payments. The problem with confusion is around BEE premiums, because some people think they go through requited. Other people think they go through unrequited. There is sometimes a bit of a tension. Then it gets through without anyone knowing which way is it getting through. That's the confusion that needs to be avoided, because that's not consistent with cost management, that's not consistent with transparency, and it's not consistent with every withdrawal counting as an appropriation rather than as a kind of blank check. So in order to achieve this compliance, this current bill, it's a relatively small amount of money. It probably shouldn't go through, but if it does go through, the simple thing to do is to say that there are no BE premiums allowed for it, because that's how it already is. And that would satisfy the Zondo report's advice, which firstly said be transparent, and secondly said the primary national interest is best served when the government goes for national value for money in public procurement. So, that should put to bed any concerns that zero BE premiums in this bill would be unconstitutional. Of course, it's constitutional. It's consistent with the Zondo report's advice. It's also consistent with Treasury's advice earlier this year during the Appropriations bill. They said let's get better value for money, improve value for money. A way to improve value for money is by getting rid of BE premiums, as this bill does. It's also very popular. 2024, we saw popular opinion. About 3/4 of South Africans wanted to get rid of BE premiums in public procurement, and 2/3 of Black respondents wanted to get rid of BE premiums in public procurement. That's according to a poll commissioned by the IRR. Done at arm's length through an independent company that's an expert in this. And then in 2025, during the budget crisis that this committee remembers very well, it went up to about 80% of South African respondents wanting to get rid of BE premiums, and 75% of Black respondents wanting to get rid of BE premiums. So this bill already does that. As we've said, it's flawed in other ways, but if it does go through, we think one of the good things that it does is it gets rid of BE premiums. No one should be dying because there's not enough money to save lives because extra money is being spent on BE premiums. This bill implicitly makes provision for zero BE premiums. If this committee thinks that's right, it should make it explicit. And if there's anyone who disagrees, if there's anyone who thinks that somehow BE premiums are part of this bill, they should very kindly explain why. Thank you very much for your time.
No, thank you very much. There's an echo, I don't know. Thank you very much, Gabriel, for the presentation. We are moving to the next stakeholder, which is COSATU. Represented by Matthew Parks to take us through his report. I wanted to say Comrade Matthew, sure. So I understand that it's not in the Mbuto, but it's Matthew who's going to represent COSATU.
Morning, Chair, morning, members. We must revisit the parliamentary protocol list and check if we can include comrades there. Can just include, I'll just put up our presentation quickly, Chair. So, yeah, I think, Chair, just to give thanks to members and to the committee, just for giving us space to do our presentation. Apologies for that, Chair. So, Chair, look, in essence, we support the passage of the Special Appropriation Bill. We think it's a necessary intervention by government to address what we all know is an urgent funding shortfall in February, March, April this year for the Department of Health. And of course, we were all very concerned about the impact upon 500,000 lives dependent upon this funding through the HIV/AIDS programs, and also the jobs of those 20,000 health workers linked to it. So we do welcome the bill, Chair. But having said that, Chair, we are deeply disappointed that we are now in November and this funding crisis took place, in February. We don't think it should have taken so long. We're also concerned, Chair, that it is quite significantly short of the actual funding shortfall that was caused by the cancellation of the U.S. funding through the U.S. aid programs. I think, as Honourable Ryder mentioned earlier in the discussion this morning, there has been some subsequent positive developments in this regard since then, not to cover the full funding shortfall, but nonetheless some positive developments on two fronts. But we do think, Chair, there is a need for a discussion in Parliament, with society, government, etc. How do we ensure that in future, when future developments happen, and they will happen in future, because this is foreign funding, we don't have a vote on whether or not it continues or doesn't continue. How do we make sure that we're better prepared as a country in future for such eventualities? I think, number one, what is the impact of the USAID funding for South Africa? We think it was really a positive, a massive impact. Since former President George W. Bush started it, 22 years ago, we've seen about 140 billion rand invested. It's estimated millions of lives have been saved. We also know that there's been more than 20,000 community health workers who are employed through public health care. That's including university, research institutions, NGO-run clinics, etc. And their work, even this year, was reaching about 500,000 South Africans living with HIV and AIDS, plus other, life-threatening diseases, illnesses. There also were similar benefits across the rest of the African continent, but with us being at the epicenter of this global pandemic, we were really a leading beneficiary of this funding. So we don't think, Chair, it's an exaggeration to say that this program from USAID and the other ones which are linked to it have helped save and prolong the lives of millions of South Africans, especially the poor. And that's been a very, very positive intervention by our colleagues across the ocean. Chair, the impact of the cut to USAID was quite painful. It was quite devastating. Number one, because of the large amount of funding, about 4 billion rand initially, but also the abruptness. It didn't give much space to government, to Department of Health, to really kind of manage issues, as opposed to if it had been given a year's notice, for example. And obviously it was, the midst of the budget adventures, drama earlier this year, so that also just added fuel to the fire, so to speak. Last year, Chair, we had, as a country, benefited from about 7.8 billion rand in PEPFAR funding, roughly a similar amount this year before the cuts. Chair, about half of this was deemed critical and life-saving, so that's where we've seen some developments. Half of it's been extended, and that's been really a positive intervention to, continue to provide healthcare for these patients, and that's been quite positive. Chair, the short notice though did make it very difficult initially, and there was real consequences. Number one was that we saw about 20,000 community health workers, NGO workers, even people employed through the USAID directly lost their jobs. There was a huge disruption to the 500,000 persons who were going to this university and other clinics to receive the treatment. We've seen also at universities too, funding shortfalls for some of the research programs which are linked to it, etc. So that's not been a good thing. And of course, Chair, I don't think one needs to mention too much here, but as members would be very, deeply sensitive to it. It just put further pressure on the fiscus, whilst we're having to manage multiple, all equally important programs, and pressing funding shortages, etc., etc. So that didn't make life easy for anybody. We support the bill in principle. I think it's common sense, it's logical, etc. In fact, we had engaged with Treasury in February already to say, can we look at options within the budget to try to address this shortfall? We didn't think we could compromise on the healthcare intervention that was being funded through PEPFAR, etc. Chair, our disappointment comes that the bill provides for about 750 million rand. The USAID funding was for about 4 billion rand. So that is a significant shortfall. But having said that, into Honorable Ryder's point, there has been subsequent developments since that time to an extent, not completely, but to an extent. But we felt that the mistake government was making was to only look at funding that was received directly by the Department of Health, which was a small amount. It wasn't the total amount, and it didn't take into account the total funding cuts through USAID, specifically those to universities, to NGOs. And that was about 4 billion rand. I think our frustration also is about how long it took. So if we're in November now, this cut took place February, and it meant from March, April, workers were unemployed. The disruption was immediate. It didn't have space to wait 6 months for government processes to kick into effect. And a lot of those workers fell through the cracks. They're unemployed. They've been plunged into poverty, and so that's not a good thing. And there's a large amount of workers, Chair. And we think, Chair, in such crises, time matters. We don't always have the luxury of kicking the can down the road. Chair, I think wanted to raise kind of Honorable Ryder's point. I'm sure other members would have the same thoughts. So there has been subsequent developments. The 4 billion rand funding cut from USAID was very painful, but we've seen two positive changes since that time. One is that, and there was a lot of confusion at that stage in February. Nobody really knew what was going on, even in the US government. The National Institute for Health, which provides about half the funding, that continued. So that's been a positive continuation. That's been very useful. And of course, the US government also had some, reconsideration around the threat to life and so on by the cuts. And so there's been an extension of 2 billion rand through the Center for Disease Control. So that's covering for the first 6 months of 2026. So that's positive because then it takes the funding shortfall from the 4 billion rand to about 2 billion rand. And then here we've got from the special appropriation bill just under 1 billion rand. So that kind of leaves us with just over 1 billion rand of continued shortfall. And that's where the universities paid the price. So, Chair, we think, this has really been, these two developments have been positive to enable this work to continue, even if it's at a lesser pace. It also kind of provides hope that as the dust settles, so to speak, in the bilateral relationship between South Africa and the US, as the relationship is kind of being addressed, it's being mended, etc., that there is space for further engagement between the US and South Africa to see how could a continued health partnership continue going forward. And that's positive, Chair. And even our own engagements as COSATU with the US Congress, I think we've seen quite positive bipartisan support from Republicans, Democrats about these programs. And that's, for us, gives us, some comfort. Chair, just getting to the end, recommendations from our side. I think we want to appreciate these are delicate matters. They need to be handled with necessary sensitivity. So you always have to manage different contradictions. We don't have a final say on such issues at all times. But I think, Chair, for us, it's about always bear in mind that the purpose of such funding is to save lives and livelihoods, especially of the poor, of the working class, who are dependent upon public health care. And also to bear in mind, Chair, that the persons overseeing such healthcare at clinics, at universities, etc., NGOs, they themselves are workers. They have also got families and responsibilities, and they themselves need to put bread on the table. And we should not just simply view them as a statistic, which can be forgotten about. So, Chair, we think this, critical Parliament obviously passes this bill, to enable Department of Health to continue to provide such services. Government needs to continue its efforts to engage with the US about continuing this partnership with the NIH, with the CDC. I think the developments have given kind of some good momentum in that regard. Chair, also we think that it's critical that, as we head towards the budget in February, that we ensure that in the budget and the MTEF, that we ensure that the Department of Health has got the resources it needs to continue such funding, because we have no say about what the US decides to do. It's their taxes after all, and if they decide to cut it, that is their choice, not our choice. So we should also not allow the Department of Health, the public health care, be put into a crisis. Chair, we think lastly, if funding can continue, that's fantastic, we would support it. But we would want to say that in future, such funding, wherever it comes from, whether it comes from the US, the EU, wherever, let's use it to build lasting infrastructure. Let's use it to build clinics or hospitals or the IT infrastructure or to buy ambulances, whatever it might be, so that even if the agreement comes to an end, which it will inevitably, we're not in a crisis. We have a lasting asset. But if we use it to fund the salaries of healthcare workers, that puts those workers and the system into a crisis when the funding stops. We think it's important just to avoid further disruptions in the future, not to put us into a crisis mode. But we'd rather use our own resources to fund salaries and use donations, grants, aid to fund infrastructure, etc. And because those will remain even beyond the funding program, just to avoid what we went through all collectively this year. So I guess in conclusion, we support the bill. We do appreciate the work done by government, led by our ally, the ANC, and other parties, to manage what is a very delicate situation. But we are disappointed how long it took, and that we didn't cater for the full impact. We just looked at the narrow, the minimalist approach. But we are heartened, Chair, that there is space to have further engagements. And again, Chair, I think it's to make the point that we should always make sure that Department of Health has got the necessary resources to fulfill its mandate and to avoid throwing them into a very difficult space. I think let me stop there, Chair. Yeah, so thanks very much, Chair, members, and let me just try to stop sharing as well.
Okay, thank you very much, Mr. Matthew, for the presentation. We are moving to I think it's going to be the last stakeholder, Mr. Robert. I'm not so sure as to whether he has connected because he was struggling with the connection. If not, just let us know as to whether he can be able to present whatever. If not, we are moving to the item on deliberation. Can I get maybe a go ahead, especially to check on him as to whether he's struggling or what is still struggling? If he's still struggling, we can move straight to deliberations.
Thank you, Acting Chair. Yes, Acting Chair, I'm in contact with him. He's struggling with his network. So I would like to suggest that the committee move to the next item of deliberations and consider his submission as a written submission if that is in order with the committee. Thank you.
No, thank you very much. It means that he has a written submission. So we are moving to if the committee agree on the written submission, are we in favor of his written submission? Anyone to say yes, and we continue to deliberations?
Agreed.
Yes, Chair.
Thank you very much. We are moving to the deliberations on the stakeholders, our stakeholders who have said this and that, their discomfort, their issues, their concern, and we are going straight to deliberation. I will see by show of hand who is taking number one in terms of deliberating on the issues. You will help me also, no, Tata.
Thank you, Acting Chair. So far, we have 2 hands or 3. Honorable Siwisa, Honorable Ryder, Honorable Swat, Honorable Majola. So far, those are the only 4 hands, Chairperson. Over to you. Thank you.
Thank you so much. We are starting with Siwisa, Honorable Siwisa. So in that order.
No, thank you, Chair. I've got only 3 questions. My first one will be to Breadline Africa. I want to check because they've mentioned other departments and they're speaking about opening a hub. They spoke about the Department of Social Services, and I think they also spoke about, I stand to be corrected, the Department of Health. But I want to check what role can public works play in the whole issue of establishing a hub? Do they consider even having public works as one of the departments that can play a role in the establishment of a hub? Other than that, Chair, I welcome their presentation. Rural health. The issue of teenage pregnancy is a great concern, Chair. We can't ignore it. The numbers are rising every day. And there are no progressive programs actually that are being implemented to deal with the issue of teenage pregnancy. And for as long as we've got a high number of teenage pregnancy, it means that the Department of Health is going to spend more, because teenage pregnancy comes with its own. Pregnancy itself comes with its own complications through the journey of being pregnant. And with teenagers, it means that there are more complications. And we are not only speaking, we can also include the HIV/AIDS, which means that more money will have to be spent when it comes to teenage pregnancy. I want to check with the rural health, because I see that they are passionate, especially when it comes to the rural areas. Do they have any suggestions or programs that they have in place that they are embarking on to actually deal with teenage pregnancy, especially in rural areas? Because we know that some of these teenage pregnancies are not reported, and some of them, they are being hidden, and some of these families are saying that these are family issues whereby you'd find that most of these girls, they are being raped by their uncles or aunts. Do they have programs where they can actually embark on, or they are embarking on, to deal with teenage pregnancy in rural areas? The TBAG submissions. They've got very solid recommendations, Chair. Nobody can argue about that. They know what they want to achieve, what their programs. But I want to check with them. The provinces that do not adhere to the recommendations that they've stated, what consequences should be implemented against such provinces, Chair? Because, Chair, as you would know, that the Committee of Finance and Appropriations, they've already started to embark on oversights to provinces to hold departments accountable. And when it comes to this one specifically, I want to check with TBEC what consequence management could be put in place to hold provinces accountable that do not adhere to all the recommendations that they've put in place, Chair.
No, thank you very much, Honorable Suisa. The next one, it's Honorable Ryder.
Thank you very much, Acting Chair. Mr. Povey, Breadline Africa, I think put forward some compelling arguments for why funding is needed, etc. But none of those arguments underpinned the bill before us. We are here very specifically to discuss the Special Appropriation Bill. Now, the need that was demonstrated, not only by Mr. Povey, Breadline Africa, but by all of the healthcare NGOs or organizations or conglomerates of organizations that presented to us today. There's no dispute. Funding is needed, and of course there's moral obligations. And in fact, I think it's opportune for us now to thank these organizations and these individuals representing the organizations for the very necessary work that they do. But I think they all confirmed what we're saying, is that the vehicle that's before us is wholly inappropriate for achieving what we hope to do. I mean, Ms. Mhlangu from Rural Health Advocacy put it quite clearly. She said, the question is not how much money there is. The question is how we spend it and who benefits. Those are her words, not mine. And I want to associate myself with those words. Because what we're seeing here is a special appropriation knee-jerk to deal with something when there's no plan to spend it. And TB accountability, sorry ma'am, I missed your name and you had a colleague's name on the screen, but you in fact argued against the bill effectively. You agreed that the lack of clarity means that we should not be giving more funding right now, and certainly not in the form of the vehicle proposed. Again, a lovely quote. There are major blind spots in oversight and accountability. What a fantastic quote, because it exactly sums up the problem that we're having. Mr. Krauss, of course, are legal. I wanted to correct you. It wasn't, this is on a lighter note, please. It's not 5 million rand for a broomstick. It was famously 238,000 rand for a mop. But I think your points were well made. You said that there was a focus on the source of the funds. I don't think so. I think equally important is both sides of the transaction. The fact is that in previous special appropriations, it's been normal. And I've gone back and I've looked at the last 7 or 8 that we've had, because it's become a habit that we have special appropriations. But I've gone back and looked at them. And though not all of them indicate the source of funds, the majority of them certainly do. And where it's not explicit in the bill, it has been detailed by Treasury in their presentations. But yeah, I mean, aside from the tongue-in-cheek comment, the mop that I used as a prop in the house is still here in my office. But yeah, thank you for your presentation. Section 27 again similarly spoke about the fact that we need a multi-year plan. A special appropriation is not part of a multi-year plan. What we're trying to do here is wrong. It's not the right thing that needs to be taken. And I think Kasatu, Mr. Parks, Father Matthew, has actually cast substantial light on the subject. And I think Section 27 gave us a little bit of information that we didn't have before, but COSATU gave us even more. And of course, now we get to the quantum of the need, which is unclear at this stage, because now we've got a response that government is saying this is what we've lost out on, so this is what we're giving. Then we have Section 27 saying, no, the need's much greater. It's going to be 5 billion. And then COSATU telling us, no, hold on a second. It's actually more closer to 4 billion, but that's made up of not only money that came to government, which is what we're trying to replace here, but that was also money that was sent to universities and directly to other NGOs. We don't understand the full picture, Chair, and I think this is the problem that we have here. We've been asked to consider something that hasn't been thought through properly, that hasn't been adequately presented to us. I personally believe that we really need the either the committee on health, be it the portfolio committee or the select committee, or alternatively the Department of Health, to come and tell us a little bit more about this funding issue, the funding need, and they can give us an exact breakdown. And this is where the department will be useful, is to tell us exactly what these funds are going to be used for. You know, they're getting this money. Do they have a plan to spend it? Do they have the capacity to spend it? We hear about all these staffing shortages, etc. Do they have the capacity to spend it? Yeah, I think Mr. Kraus, going back to his comments, if you look at how the money is being spent, that middle column that deals with goods and services gives scant information and covers such a small proportion of the money that's been appropriated. There's not enough info. It's not going to salaries. It's not going to goods and services. Where is it going? So, Chairperson, in conclusion, I really don't think anyone here has given us compelling inputs into why this bill should be passed in its current form. I honestly think that Treasury's got some serious answers to come with to tell us why this bill should not be withdrawn. And if we are to push through with it, I really believe that we need a lot more time and effort looking at inputs from the Department of Health, the Portfolio or Select Committee on Health, I'm not fussed about which one, that can help us to come to a good conclusion and to make a good decision. Because at the moment, we are shadow boxing in the dark. Thank you, Chair.
Well, thank you very much, Honorable Ryder. The next one is Honorable Swart.
Chair Lady, I'm actually covered just by the previous speaker, but just my cent in the hat. The problem is, Chair Lady, the issue is that really, and I've heard from the concerns also from all the presenters. But, you know, just also from my side, the issue is that our provincial health systems are already overstretched, understaffed, and in several cases unable to absorb funds effectively to spend them in a way that protects frontline services. This bill, you know, as currently framed, it shifts the responsibility onto the provinces without ensuring the capacity, the systems, or the accountability mechanisms needed to actually deliver services. You know, we cannot just simply transfer money into provincial grants and hope that it reaches community health workers. Outreach programs, testing sites, and treatment adherence support. The evidence before us shows exactly the opposite risk. Funds must be absorbed into provincial, maybe absorbed into provincial deficits. NGO and community health workers program are not guaranteed continuity. Rural and high burden districts will be the first to see service gaps. And the question is not, is the bill necessary? The question is the bill effective without ring-fencing, implementation plans, and direct reporting to Parliament? Chairperson, I'm not going to go into all the presentations, but I agree with the previous speaker. Thank you, Honourable Chairperson.
Thank you, Honorable Swart. The last hand is from Honorable Machola.
Thank you, Madam Acting Chair. Two fundamental observations, Madam Chair, from all stakeholders' presentations that one have learned from it. One being that the advice from, or the recommendations from most of the stakeholders to Treasury, emphasizing the fact that we need to make it sure that we make funding available, internal funding available to fund these constitutional functions. The other one, it was emphasized by the TB Accountability Consortium, is the issue of the provinces to account for the money that has been transferred to them. Those are the two basic lessons that one has learned from the presentation. But with regards to the questions, two questions arising from presentation. One, it's direct to COSATU, having their recommendation on slide 13, which is the one that I highlighted, to make funds available. But they further on bullet 2 emphasized the importance of the South African government to continue with the engagement with the USA government. I want to check with the COSATU whether they still regard the unreliable aid from USA for South Africa to base our plan in terms of this constitutional mandate to rely on this funding. I want to check whether are they still see as an important exercise to engage to the SA government. The second one, it's the baseline with regards to the statistics. I'm not sure whether was it a misprint where they indicated that 84% lack the ID documents in that particular area, which is Komati, Ward 4. That's a huge number. I want to check as to whether is it correct, or if it is correct, has there any engagement with the relevant department, which in this case is the Department of Home Affairs, regarding that low pace in terms of acquiring the ID document. Well, Madam Chair, as I indicated, there was also an emphasis from Duduzi from Section 24, emphasizing the over-reliance to the donor for the constitutional mandate health services. That's exactly what I've indicated. Having said that, Madam Chair, thank you very much with those two questions. Thank you.
No, thank you very much, Honorable Machola, and all the honorables that have asked a question. I will go back to our stakeholders as to, according to the list, Redline Africa, if ever we have got anything to say, and I will take that list up until to the last one. Redline.
Thank you, Chairperson. Let me address based on what I heard from Honourable Suisa on how we can interact better with the public works. So a quick 5-point plan is infrastructure delivery for the health and ECD integration.
You are breaking. We are breaking.
Can you hear me now? Is it better?
Yes, I can hear you. Just stand there so that we can.
Perfect.
Yeah, it's better.
Thanks.
Continue.
So the 5-point plan for public works and Breadline Africa, I think we could work together on infrastructure delivery for the health and ECD, inclusion in the infrastructure investment plan going forward. Definitely need assistance with coordinating with municipalities and an advisory role from the technical point of view on compliance and engineering. And then I think finally is being part of a public-private partnership, sitting together and let's working on a plan together. That's for Honourable Suisa. Honourable Rada, thanks for your feedback, and I take it. I take those points, and I will in future reference my presentation more closely to the bill. I think in a nutshell, we support the intent of this bill. But I think, like you've emphasized, is that there probably needs to be some more working on it. And Honourable Majola, with a number on ID documents in Komati, that is from a sample size, so it's not the complete town. It is the sample size, and it's mainly of the children in the area that we realized are lacking in ID documents. But we are trying to work closely with both Department of Home Affairs and the municipality to get this rectified. Thanks.
Thank you so much. I had a question from Honorable Siwisa. Thank you so much for your question. And I totally do agree with you that teenage pregnancy in South Africa, especially in rural areas, is a big problem. And as the Rural Health Advocacy Project, we actually do support this argument, and we have written policy briefs that were published around Youth Month in the year 2024 and 2025. And in our policy briefs, we do actually give our suggestions on this problem, because teenage pregnancy is actually a very big problem and major concern in South Africa, especially in the rural areas where access to sexual and reproductive health services is very limited. We suggest that strengthening adolescent-friendly services through surveys, focus groups, and trained youth-oriented healthcare providers can make the health services more accessible and relatable. We also suggest that expanding contraception access in schools and ensuring consistent supply in clinics will help reduce the barriers and also the stigma that is occurring around teenage pregnancy and the use of contraception as well. We also suggest that there must be comprehensive education and media campaigns which are needed to increase the awareness of teenage pregnancy and encourage the uptake of contraceptives among the youth. And promotes. We also suggest that there should be a promotion and shared responsibility among both genders. Ultimately, a coordinated approach between health, education, and social services is very essential to reduce adolescent pregnancies and support young people's health, education, and future opportunities. So basically, we also do suggest that there must be some multi-sectoral collaboration that is occurring so that we can fight against this problem. But thank you so much for your question, and thank you to everyone else for your recommendations and your comments.
No, thank you very much. The next one must follow. I'm not so sure here. I was a bit disconnected. TB.
Yes, Honourable Chair, thank you so much. And to the honourable members who had given their comments and questions, thank you so much. Yes, my name is Sihle. I think it was from Honourable Siwisa's question initially. Just as a first observation point that Honourable Majola had given around the acknowledgement of learnings. I think these public hearings, if anything, are testament to the shared learnings and observations that us as civil society, as well as you as duty bearers, is something that is needed in terms of not just as critique, but in learning of what is happening on the ground. And I think as civil society members who some of us are our, local level, leadership as well as community, leadership. I think it's important for these, public hearings to be of shared, learnings. And so we thank you for that observation. I think there were just two questions. Firstly, of Honorable Sirisa around the consequent management. If and when should consequence management be placed? I think the measures are within the Minister of Health, as well as within the National Treasury. And I think, in this mechanism, the Minister of Health can invoke Section 100 in terms of, what are, mechanisms that can be placed if there is a province that underperforms or does not work within the that does not work within the frameworks of the plan or the bill in this context. But we've seen that there has been limited power, as we've seen in other provincial failures. But similarly, National Treasury can improve the management of the conditionalities of the conditional grants. And maybe that is a mechanism in which this consequent management can actually be enforced. And then lastly, I think the committee yourselves can also invite the national and provincial treasuries in terms of having a more strengthened accountability loop within how these things are actually done. And then secondly, I think it was through Honorable Ryder in maybe inferring that within our presentation that we do not support the bill. And I think we'd want to say, in contrary, we do support the bill and we support the intent of it. But the governance mechanism is one that needs transparency and a complete accountability loop. And I think that's where maybe there needs to be a revisement in terms of if we're wanting for this money to then be, dispersed within provinces. It's not to say that the bill cannot be actioned, but there needs to be a strengthened accountability loop from national policy to provincial implementation. And so linking to SWAT, to Honorable Swat's comment, is that we're needing a efficient ring fencing mechanism in the protection of services. And I think everyone here is actually in agreement around that. And I think that that's ultimately what we're wanting to have, is that we don't just have money that is not overlooked, but there needs to be transparency and accountability that follows through that. Thank you so much, everyone. Thank you, Honorable Chair, and to the Honorable members.
Thank you very much. The next one is Nkosi Mduduzi. Do you have anything to say?
Thank you, Honorable Chair. I don't think there were questions directed at us specifically, but we appreciate the comments of the honorable members. And
no, it's fine. You are our stakeholder. We must give you enough time to say whatever you want to say. Let's take the Institute for Race Relations. Mr. Gabriel, do you have anything to say?
Greetings, Chair. Thank you. I believe that I started my presentation by correcting the acting chair's misattribution of the organization that I represent, and yet that mistake has been repeated.
Okay, just say it again, because I'm reading.
Legal.
Okay, no, it's fine. It means they must correct it from here because they've sent me my apology for the wrong whatever.
Okay.
Yes.
I appreciate the apology. That's all good. Okay. Chair, I take Honourable Ryder's point. The focus has been both on the source of the funds and the directions that the funds are going in, and it's clear that transparency is required on both, and that the intention of a bill may be as noble as can be. The bill could say we could have a money for good deeds bill, and it can be written there, we're going to spend 750 million rand on doing good deeds. And there could be no greater or more noble intention than to do good deeds. But of course, that would not satisfy the basic legal requirements, including of the Constitution. because it would not be transparent and specific. Well, what in particular is the money going to, and where is it coming from? But Chair, I just want to ask, there was a bit of a signal disruption on my side, so I might have missed something. Were there any members that directly addressed the specific recommendation of an insertion of clause 1.4 to make explicit that which is implicit, that no withdrawal is being made from the National Revenue Fund in this Act to pay for any premiums for preferential goals?
Okay, there is a question here from Mr. Gabriel. Is saying, in terms of the revenue there, anyone who has an answer on what is presented to us to say, I can't really say whatever he has said, but if ever there's anyone who has an answer, he can be able to assist us, or you can write a written submission so that we can be able to assist in terms of making sure that you get the necessary answer. I will be guided so that we can move to the next one.
Okay. Thank you, Chair. Shall I? Sorry, Chair. I really appreciate it. I just want to say, it really is a very simple recommendation. The idea is this bill currently does not withdraw funds for BE premiums. And the recommendation is just to say that explicitly in the bill, to say this does not withdraw BE premiums. Of course, an appropriation bill is a withdrawal. It is a law that allows money to be withdrawn from the National Revenue Fund. So we just want to say, we recommend that you make it clear that none of this is being withdrawn for BE premiums. And we would very much appreciate to know if any members are against that idea, they don't want to make that change, for them to engage by explaining why they do not want to make that change. And we of course, I think everyone is aware of the case law, the precedents set by the Constitutional Court in terms of public participation, that this is not just a box-checking exercise where you allow people to speak and you ignore them. There is an understanding that there is an application of the mind. And so we know we are just a civil society organization. There is no requirement for any member of this august committee to vote or act in a way that we recommend. But we would very much appreciate the chance for an application of the mind to occur so that we can understand if our recommendation is not taken up by this committee. Why is it not taken up? And if it is taken up, of course, we'll be very happy. But if it's not, we would very much appreciate the chance to know why. And at this stage, if emails are sent so that we can answer in writing, someone wants to say, well, maybe we don't want to do it, maybe we do, but this is our concern. Of course, we would be very glad to answer that in writing or in any fashion that the chair or the committee suggests. Thank you very much.
No, thank you very much. I will do follow up so that they can be able to answer you in writing.
Thank
you. And be able to get all the answers. Thank you very much. We move to the next one, which is COSATU. Mr. Matthew Parks.
Okay. No, thanks, Chair. Thanks to honourable members. I think it was just two questions. I think the first one from Honourable Ryder, and I think, Chair, we must upgrade Honourable Ryder to a comrade. I think he's in the title. So on a serious note, Chair, so I think Honourable Ryder is right. There's a lot of confusion flowing all around, and that's partly because these things happen so quickly. To be fair to government, you wouldn't, this government wasn't given, a year's notice, etc., which would be a norm or whatever. It was given a few weeks, and it was communicated on Twitter. Even when there was attempts to engage with colleagues in the US. What exactly is the scenario? Even they were not completely sure. So I think that's why there was a lot of confusion. I think in terms of the numbers, our understanding, and colleagues in the Department of Health would obviously have a deeper understanding, is that you're talking about 8 billion rand in total from USAID, but also from the National Institute for Health. Half of it came from USAID, so that's the one which fell into trouble. That was the one which was cut as USAID was cut back, closed, etc. So you had about 4 billion rand, and then out of that 4 billion rand, there was about 2 billion rand, which was subsequently extended through the Center for Disease Control. So that covered about half the shortfall. Then of course this supplementary bill, which we support as passage, covers about 754 million rand, so about a quarter of the shortfall. So it still leaves about 1.25 billion rand shortfall, and that's why our kind of frustration with government occurred, is that yes, the shortfall for the fiscus might have been that 1 or 2 billion rand or 3 billion rand, whatever it is, but there was others who were part of the same kind of funding programs outside of the state, university clinics, NGOs, research institutes, etc., all providing a valuable role and all put into a real crisis where they didn't have a fiscus to fall back on. And what it meant is that human beings were retrenched. Workers had a job of providing a valuable public service, saving lives, etc., supporting the public health care objectives of the state, and then they were just sent through no fault of their own chair. So I think that is the one kind of concern. And so I think we would have wanted a more holistic approach, which is what is the total funding cut back for the country, not just for the state, but NGOs, universities, institutes, etc. So I think for us, that's where we do need to have a useful discussion going forward. And I think also, Chair, to Honourable Majolo's question as well, we'd be keen for funding to go forward. We're still a developing nation. I think we all know what former President Thabo Mbeki eloquently captured as two nations in one country. So funding is useful. I mean, this program, Chair, the last 22 years has covered about 500 million participants annually, saved millions of lives. There's a benefit to the economy, to public health care being overburdened, etc., etc. It's helped to employ 20,000 workers, etc. That's a good thing. We have been heartened by subsequent developments from the kind of the dark days of February. That NIH funding has continued. That's about 4 billion rand, and of course the extension through CDC of about 2 billion. So we think, Chair, that once the kind of dust settles this year, there is space for still further discussions. Obviously, we can't tell the US as a sovereign country what they must do, but we think there's space to have such discussions. Definitely worth an engagement. But I think, Chair, to Honourable Majolo's point, I think that's the kind of one recommendation we are making is that, be it from the US, be it from Europe, be it from China, the UN, doesn't matter where it comes from, or business, wherever. Any funding we get in the future, we should ideally, Chair, let's use it for a lasting asset. Be it a physical building for a clinic, be it IT systems for hospitals, be it ambulances, medical supplies, whatever it is, some sort of lasting, tangible asset, so that when funding does come to an end, and it always will come to an end, we don't get thrown into a crisis like we were in February, March, April this year, where health workers unemployed, clinics close overnight, patients thrown into a life-threatening crisis. So I think that's our plea, that in future when government receives aid, let's really ring-fence it for things which the world won't end when the funding comes to an end. I guess that's our point, Chair. But I think we do want to appreciate the efforts of government to manage it. But I think for us, Chair, I think what other colleagues also raised, that we're disappointed, one, we took so long, and two, about the funding shortfall. But let me stop there, Chair, and thanks to honourable members and yourself, Chair. Thanks, Chair.
No, thank you very much, Mr. Parks. Let me allow, if ever there is a follow-up from our honourable members, if ever there's something that they feel has been left out, to give them this chance. If ever there's anything like that, before we can come to the conclusion of our meeting.
Honourable Ryder's hand is up, Acting Chair.
Okay, it's only one. It's only Mr. Honorable Ryder send.
But it's all the same names.
Yes, Chairperson, but yes, Chair.
Okay, no, thank you very much. If that is that, we'll allow Honorable Ryder.
Yeah, I don't think it's appropriate to enter into a debate, but I think that making comments on a special appropriation bill, that there needs to be a bigger plan, there needs to be more transparency, etc., which is exactly what Rural Health did, indicates that it shouldn't be a special appropriation, that it should form part of the normal, proper annual performance plan process, and they should be engaging in the BRRRs and engaging with adjustment budget processes and so on. It's not that attaching comments like that to a special appropriation means that there shouldn't be special appropriation, and argue strongly against approving this bill. Just a point I wanted to emphasize from my side. I don't think it's necessary to debate it. I know they will feel differently, but we all know that if you ask the health department to come up with a plan, it's not going to come up with a plan in the next 3 weeks. It will take them, well, on a good day, it'll take them 6 months. But thank you.
No, thank you very much, Mr. Ryder, for those advices. We have come to the end of our meeting. We have allowed our stakeholders to take out their concern. We have also allowed honorable members to ask a question and be clarified. So we have come to the end of our meeting. I want to take this opportunity to thank all of our presenters and members for the constructive engagement today. The committee notes that the Special Appropriation Bill is a necessity measure to maintain continuity of essential HIV and AIDS and community health services following the withdrawal of our donor funding. We are guided by Section 27 of the Constitution, which requires states to avoid regression in access to health care, and by the Money Bill Act, which mandate us to ensure that appropriated funds are used efficiently for the intended purposes. We also acknowledge the issues raised by regarding provincial capacity, community outreach, and long-term sustainability. These matters will receive continued attention through the committee's oversight processes. We thank the FFC and all the stakeholders for their input during this public hearing. I want to take this opportunity to thank all of you, honorable members, our stakeholders, for your contribution in today's meeting. So with these few words, I want to thank all of you, and our meeting stands adjourned. Thank you very much.
Thank you, Acting Chair.
Thank you, Acting Chairperson. Thank you, honorable members.
Thank you, everybody.
Long live the Acting Chair.
Thank you, Chair.